बहुत ज़रूरी है। आफ्टर ऑल हेल्थ इज वेल्थ।
I think healthy beginning plays important role in bright future. I have to play important role in disseminating this information.
हमारे उज्जवल भविष्य के लिए हमारे स्वास्थ्य का ध्यान देना बहुत ज़्यादा ज़रूरी है।
मैं यहाँ पे आज वैक्सीनेशन के लिए आई हूँ। मेरे 2 बच्चे हैं, रिद्वी एंड दिविशा। मैं उनका बहुत अच्छे से ध्यान रखती हूँ और अपना भी, उनके साथ साथ मैं अपना भी ध्यान रखती हूँ। मैं ठीक रहूँगी तो फिर मैं अपने बच्चों का और अपने परिवार का ध्यान अच्छे से रख पाऊँगी।
मेरे बच्चे के लिए सबसे पहले प्यार भी ज़रूरी है, हेल्थ ज़रूरी है, उसके बाद पढ़ाई ज़रूरी है।
सबसे पहले तो स्वास्थ्य ज़रूरी है और उसके बाद शिक्षा भी उतनी ही ज़रूरी है जितना कि स्वास्थ्य ज़रूरी है। और ये जब दोनों चीज़ सही से चलती है तभी जीवन आगे सही से चल पाता है। मैं अपने मिसेज और अपने दोनों बच्चों का स्वास्थ्य का बहुत अच्छे से ख्याल रखता हूँ। मुझे ऐसा लगता है कि स्वस्थ शुरुआत उज्जवल भविष्य के लिए ज़रूरी है।
ऐसा नहीं है कि बेबी के बीच में आप अपने आप को भूल जाइए। अगर आप अपना ध्यान रख रहे हैं तो बेबी भी आपका अच्छे से खेलेगा, खाएगा। तो अपनी सेहत पे भी ध्यान रखिए, अपने बच्चे के ऊपर भी। मैं एक चीज़ और कहना चाहूँगी पेरेंट्स से भी और सभी से कि बच्चों को जितना हो सके उतना मोबाइल फ़ोन से, टीवी से दूर रखिए।
मैं माँ बनने वाली हूँ और मैं बहुत एक्साइटेड हूँ और मुझे इस चीज़ से कोई फ़र्क नहीं पड़ता कि मेल है फीमेल है, और मैं बस ये चाहती हूँ कि मेरा जो भी बच्चा हो वो बस हेल्दी हो।
बेटी का भी रखती हूँ, साथ साथ में अपना ध्यान भी रखती हूँ खाने पीने का, तो क्योंकि मैं सही रहूँगी तभी बेटी को मैं सही रख सकती हूँ।
Emotional support from the end of husband Kenyan is very important at the time of for mother especially for a healthy future.
A healthy beginning is important.
constant fever, I was unwell, and especially during evenings, the fever would recur. I was diagnosed with urinary tract infection, and Klebsiella was the cause of the infection. Several antibiotics were tried by the doctor, and it did not work for me. It took 3 months. The blood test was done on 18 different antibiotics, and none of them were effective. The doctor then had to take recourse to the latest cutting-edge antibiotic as well as a mixture of antibiotics. It took 6 months for me to get cured. The disease took a heavy burden, made me tired, made me depressed. It did not allow me full physical functioning, and it took several visits to the clinic before the diagnosis could be made and treatment could be given. The treatment took time, and it took time for the doctor to be able to arrive at a diagnosis which was consistent with what I was reporting and to get a cure for it. Spread of AMR will have huge mortality and morbidity consequences on the populace.
എൻ്റെ പേര് അബ്ദുൽ സമദ് കൂരിക്കണ്ടി. കോഴിക്കോട് ഡിസ്ട്രിക്റ്റിൽ കൊയിലാണ്ടിക്കടുത്തുള്ള പ്രദേശത്താണ് എൻ്റെ താമസം. 2022 ജൂലൈ 26 എനിക്ക് കാലിന് ശക്തമായ വേദന ഉണ്ടായിരുന്നതുകൊണ്ട് പിറ്റേ ദിവസമാണ് ഡോക്ടറെ അടുത്ത് പോയത്. ഡോക്ടറെ അടുത്ത് പോയി ഡോക്ടർ ഗുളികകൾ തന്നു, മാറിയില്ല. വേറൊരു ഹോസ്പിറ്റലിൽ പോയി. അങ്ങനെ 4 ഹോസ്പിറ്റലിലേക്ക് പോയി. ലാസ്റ്റ് ഇക്രയിലാണ് പോയത്. ഇക്രയിൽ നിന്നാണ് അവിടുന്ന് MRSA എന്നുള്ള അസുഖമാണെന്ന് കണ്ടുപിടിച്ച് മനസ്സിലാക്കി ഡോക്ടർ തന്നത്. പിന്നെ തീരെ വയ്യാത്ത അവസ്ഥയിലായിരുന്നു കിടന്നിരുന്നത്. അനങ്ങാൻ കഠിനമായ വേദന ശരീരത്തിൽ മൊത്തം അത് ആവുകയും ചെയ്തു. വ്യാപിച്ച് കയ്യിലും കാലിലും നട്ടലിനെല്ലാം വ്യാപിച്ച് കൂടി വന്നു. പിന്നെ ഫിസിയോതെറാപ്പിയുടെ ഹെൽപ്പൊക്കെ ഉണ്ടായിരുന്നു. അവിടെ നിന്ന് എല്ലാ ചികിത്സകളും അവിടെ നടത്തി 15 ദിവസം കഴിഞ്ഞതിന് ശേഷം വീട്ടിൽ വന്നു. ആൻറ്റിബയോട്ടിക്.
ഹലോ 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 Mi mám tiếng Hàn thẹt đấy.
Check. 1, 2, check. Check. 1, 2, check, check, check. Check, check, check. Check, check, 1, 2, 1, 2, check. Check, check, 1, 2, 1, 2, check. Check, check, 1, 2, 1. Check, check, check.
Check 1 2. Check 1 2. Check 1 2. Check 1 2. Check 1. Check 1 2. Check 1 2. Check. Check 1 2. Check 1 2. Check. Check 1 2. 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 Check. Check 1 2. Check 1 2. Check 1 2. Check.
Do you want to say it?
Check 1 2.
लॉन्च के बाद देना ठीक है ना दैट्स अ कर्टसी ना जिसे अपने डिक्लेरेशन भी हो उनको बोल दिखाना मत बाकी नहीं है आई एम श्योर देयर आर 25 ऑफ देम हैव कम मतलब पीपल लाइक मी उससे जरा सा पूछो किस किस को दिया है किससे बता देंगे they tell you who all are getting this ये कल टेबल पे खोल के आया था हां वो खोल के देखी सारी मैंने दो थे ना मतलब इसमें पूरा मिला के 15 5 नहीं है 10 वो में ठीक है तो चलो ठीक है तो बाकी अगर मिल जाता है तो दे देना वैसे कम से कम 25 के 30 आए हैं दोनों बराबर आए हैं सेम नंबर वो जिसको देना है वो नहीं दिया अभी हाँ तो उसे हाँ रखवा दो वो तो रखवा दीजिए और जैसे वो करेंगे स्कैन करेंगे बिल्कुल थैंक यू have time now. You're the boss, right? You're the boss. इसका एक चैनल रहता है ना, इससे एक चैनल से ही सारा जानना चाहिए, जैसे कि क्लैरिटी है नहीं लगे अब क्या हो गया क्या हो गया. So the clarity now or the clarity is when the book is being released, that code will be shown. तो उस समय दिखाया जैसे ही किताब को रिलीज करके नीचे रखा वीडियो चल गया because उसने पहले ही अनाउंस कर दिया है कि we will have the book launch followed by this, so that is already announced. उसमें डाल वही डालना है.
हम एक कॉपी दे देंगे डेलीगेशन को.
Good afternoon. Please prepare when we like to start the afternoon session of the 28th RC. Please fill the inner U-shaped table. Let's see if we can form a quorum and we can start.
Excellencies, distinguished representatives, welcome back. Hope you are feeling energetic after a wonderful lunch. I thank you all for your active participation and insightful observations at the Ministerial Roundtable. I now call the meeting to order. Now onwards, for the interventions on the agenda items, I would appreciate maintaining a maximum time limit of 3 minutes. Accordingly, the traffic light will be green for 2 minutes and will turn amber for the last 1 minute. It will turn red once the allocated 3 minutes time limit is over. Let's now take up agenda item 8, policy and technical matters. As you may observe, this agenda item has 4 sub-items, so let us take them up one by one. Let us take up the first sub-agenda item 8.1, Annual Report on Monitoring Progress on UHC and Health-Related SDGs. The 2030 Agenda for Sustainable Development, adopted by the UN General Assembly in 2015, includes 17 aspirational sustainable development goals to be achieved by 2030. The agenda categorically emphasizes that no one is left behind on the road to health and well-being. Among these, the health goal SDG 3 aims to ensure healthy lives and promote well-being for all at all ages. The 7th session of the Regional Committee for Southeast Asia in 2017 requested the Regional Director to include an annual report on monitoring progress on UHC and health-related SDGs as a substantive agenda item until 2030. This year is the 10th annual report on monitoring the progress of Member States towards achieving UHC and the health-related SDGs in the Southeast Asia region. Each year, this progress report focuses on a specific health-related items in addition to monitoring overall progress towards UHC and the health-related SDGs. The thematic focus on this year's report is on the regional progress in strengthening the role of the health sector for improving civil registration and vital statistics in the Southeast Asia region, 2015 to 2024. This working paper and the HLP meeting recommendations are submitted to this 78th session of the WHO Regional Committee for Southeast Asia for its consideration. I now give the floor to the distinguished delegates to make observations on this item. I now give the floor to India.
Sri Lanka. Sri Lanka.
Sorry, Sri Lanka.
Yeah. Thank you, Chair. The government of Sri Lanka established the Sustainable Development Council under the Sri Lanka Sustainable Development Act number 19, 2017 to coordinate, facilitate, monitor, evaluate and report on the implementation of the 2030 SDG agenda. Currently, over 400 government agencies are working to achieve the SDG goals. In 2024, SDG country ranking was placed 93rd out of 167 countries with an SDG index score 67.9, identified as the country as a front runner in achieving the SDGs. Notably, SDG 3, good health and well-being, showed moderate improvement. UHC index was 67 in 2024, and it is estimated to reach the 72% by 2025. However, proportion of the population with out-of-pocket health expenditure exceeding 40%, household discretionary income was 11.3% in 2019. This figure remained high, highlighting the continued need to strengthen financial protection mechanism to reduce the economic burden of healthcare cost on household, particularly among vulnerable populations. Sri Lanka is currently undergoing a significant epidemiological and demographic transition. The fertility rate has declined to ultra-low level of 1.3 in 2024, while the aging population continued to grow. NCD is now account for nearly 80% of hospital death, contributing heavily to premature mortality among aged 30 to 69 years. To respond to these challenges, Sri Lanka has initiated the strengthening and restructuring of primary healthcare system through a comprehensive and integrated approach that focuses on improved service delivery for NCD, disability, aged care, and palliative care, along with the community empowerment, digital innovation, sustainable financing. This transformation of PHC into people-centered, equitable, and resilient system is central to achieving universal health coverage and improving population well-being. Under the current national plan, Sri Lanka aims to establish 2,000 primary community health centers over the next 3 years, each serving approximately 10,000 people. These centers will enhance the improvement of NCD services, continuous professional education for healthcare workers, and the development of standardized treatment guidelines also being implemented. Despite ongoing progress of human resource shortage and the 47% of out-of-pocket expenditure remain key challenges, the government has begun implementing task shifting and role redistribution strategies and developing sustainable finance policy to optimize the use of available staff and maintain service delivery. This integrated effort reflects Sri Lanka's strong commitment to sustainable development and equitable healthcare for all citizens, and aiming to achieve an 80% UHC index by 2030. Thank you, Chair.
Thank you, Sri Lanka. I give the floor now to India.
Good afternoon. Thank you, Chair. India acknowledges the WHO Southeast Asia region's progress in monitoring universal health coverage and health-related SDGs. India aligns with the regional UHC service coverage index improvement from 47 in 2010 to 62 in 2021. India supports strengthening monitoring frameworks using revised SDG 3.8.1 and 3.8.2 indicators for more accurate UHC progress assessment. Chair, India's approach to translating political commitment into measurable outcomes is firmly anchored in its National Health Policy 2017, which envisions an equitable and resilient health system driven by sustained public investment in healthcare and reflects India's deep commitment to ensuring quality healthcare. Guided by the principles of accountability and result orientation, India has institutionalized the National Quality Assurance Standard framework, setting clear and measurable benchmarks to drive continuous improvement and excellence in healthcare delivery. India also employs data-driven governance using platforms like Mera Aspatal for real-time feedback and Ayushman Arogya Mandir portals for service tracking, enabling policy corrections and performance-linked incentives. These mechanisms collectively strengthen fiscal accountability, transparency, and progress tracking towards universal health coverage and sustainable development goals. Chair, WHO and its partners can play a catalytic role in strengthening context-specific technical cooperation, capacity building, and cross-country knowledge sharing. India welcomes enhanced collaboration to support the implementation of ICD-11 and verbal autopsy systems, thereby improving data quality for civil registration and vital statistics. WHO's continued technical assistance in digital interoperability, CRVS modernization, ICD-11 adoption, and data governance frameworks will be key to advancing regional data maturity. Sustained investment and collaboration in these areas will ensure that reliable, actionable data inform national and subnational decisions, improve accountability, and strengthen progress towards UHC and health-related SDGs. Chair, India strongly recommends that WHO consult member states when updating UHC progress data to ensure accuracy. Our national indicator framework reports 6.67% catastrophic health spending, contrasting with WHO's reported 17.5%, highlighting the need for data reconciliation. We also suggest that WHO adopt country-level data verification processes and integrate member states' national monitoring frameworks into regional assessments, ensuring that WHO reports accurately reflect country-specific progress towards UHC and the SDGs. Thank you.
Thank you, India. I now give the floor to Bhutan.
Thank you, Chair. Distinguished delegates, first we would like to take note of the report and thank the Secretariat for the comprehensive update. We commend the achievements, particularly in reducing maternal and child mortality, controlling HIV and malaria, and expanding health workforce in our region. These are important milestones that show the impact of collective regional action. In Bhutan, it's a state policy enshrined in our constitution to ensure financial protection during events of disability and sickness, and to provide free access to basic health services. In the National Health Sector Strategic Plan, Service Coverage Index not only considers the traditional indexes, but additionally includes traditional medicine with 4 tracer indicators covering both demand side and supply side functions. Bhutan is concerned that the region is not on track to achieve the global UHC Service Coverage Index target of 80 by 2030. The rising level of catastrophic health expenditure are not only alarming, but calls for reinforced policy measures, systems thinking, and targeted interventions to support the population to stay well while living well. Bhutan, although has relatively lower levels of catastrophic health spending, but we do recognize the fragility of these gains, especially in rural and remote communities. Therefore, strengthening financial protection and equity must remain central to our region's health policies. In conclusion, Bhutan will continue to place strong emphasis on achieving all our health-related SDGs, SDG targets, and UHC. Thank you, Chair.
Now I give the floor to Timor-Leste.
Thank you, Chair. We acknowledge the report and commend steady progress made in service coverage across the region. Timor-Leste says the common concern about the challenges ahead in achieving the health-related SDG target. Allow me to highlight 3 key areas of progress. First, primary health care. Since our independence 20 years ago, every government has prioritized primary health care as the foundation of our health system and the most effective path to universal health coverage. Next year, 70% of our national health budget will be dedicated to primary health care. Second, integrated service delivery. Through our flagship program, Integrado Saúde, We are strengthening services coverage with the new vaccine such as HPV, major upgrades in TB and dengue control, expansion of school health services, and the national rollout of NCD prevention and management of primary level. Third, the disease elimination. We have successfully eliminated malaria, filariasis, measles, tetanus, and rubiola, are close to eliminating yaws, trachoma, and leprosy. However, the challenges remain. Quality of care continues to be a concern despite the expansion of our essential service package, and sustaining the ambitious peace program require continuous effort and research. Our approach is guided by the CRC 67 in an R3 resolution to strengthen primary health care as the cornerstone of universal health coverage, integrated preventive, promotive, and curative service for all. Going forward, Timor-Leste is committed to expanding community outreach and home visiting to reach underserved population. Second, to strengthen integrated services delivery to improve health outcomes and building capacity of health workers and engaging community for resilience primary health care. And also, we are considering in monitoring progress to align with the regional universal health coverage targets. With WHO continued guidance and partnership, we remain determined to ensure the healthier and more equitable future for all Timor-Leste. Thank you.
Thank you, Timor-Leste. Now I give the floor to DPR Korea.
Thank you, Chair. Since the 70th session of the WHO Regional Committee in 2017, the WHO Southeast Asia Regional Office has been developing and issuing the annual report on monitoring progress on universal health coverage and health-related sustainable development goals. DPR Korea appreciates this as this report plays the important role for analyzing the progress gained and lessons learned as per individual indicators and identifying the direction for future improvement. The thematic focus of this year's report is around the role of health sector for improving civil registration and vital statistics, particularly the need for strengthening the registration system of birth and death and record of medical cause of death. We think that this focus is well chosen, being grounded upon profound insight into the crucial role of statistics for protecting the health of general population and strengthening the health system. During his visit to Pyongyang General Hospital nearing its inauguration, President of the State Affairs of DPR Korea said that it is needed to build an advanced and efficient digital medical service network and medical treatment system in city and county hospitals. And he also put forth a task for establishing a nationwide public health and medical service infrastructure comprising central hospital, provincial, city, and county hospitals, as well as individual families. In DPR Korea, much effort has been driven to increasingly enhance the UHC and achieve the targets of health-related SDGs, which resulted in tangible progress towards them, including the mortalities of maternal, newborn, and child of under 5 age. This is all thanks to the advantageous public health policy of our socialist system in our country. We believe that WHO CRO needs to step up its role of a catalyst for ensuring the universal health coverage accessible to everyone of all member states within this region. In recent UN assemblies, a series of high-level meetings have addressed this agenda of UHC, which claims that the health must be the due right of every human being rather than the benefit enjoyed by a specific class alone. And all member states reaffirm their commitments to this in those events. For ensuring the elementary rights of human beings, it's critical for everyone to benefit from the medical service as best as possible in any context and condition, regardless of their gender, occupation, race, and property status. The regional office is required to display its duty to facilitate all member states to translate their political will into action for this effect. We also insist that health intervention must orient towards preventive medicine. In recent years, we all witnessed COVID-19 pandemic, which caused mega socio-economic disruption on global scale, and the potentiality of such risk is still with us. Once health risk is preventive medicine perspective, the health of people can surely be protected from such risk, and spending on health sector might be saved. We suggest that WHO CRO office can further build up the technical assistance and cooperation for member states with focus on advancing towards UHC and preventive medicine. Thank you.
Thank you, DPR Korea. Now I give the floor to the Maldives.
Thank you, Chair. Maldives appreciate the importance given by your team in bringing this vital agenda item for discussion. Maldives is working towards achieving universal health coverage by strengthening primary health care through investments in infrastructure, workforce training, community involvement, and health promotion and prevention. This is done through reorientation of health systems across the country rooted in PHC. Maldives provides equitable access to comprehensive quality health services for everyone without financial hardship. Today, every birth and death is registered almost in real time, and every medical certificate has cause of death is completed before the burial, allowing us to have reliable, actionable data. These data are actively used to guide policies, monitoring non-communicable diseases, establishing a cancer registry, and expanding dialysis services. Our commitment is also reflected in the enactment of the Birth and Death Registration Act of 2022, which formally integrated birth certificates and national identity cards through a collaborative multi-sectoral approach. Building on this legal foundation, CRVS technical and steering committees now provide an institutional mechanism for coordinated engagement, enabling identification of gaps, prioritization of actions, and evidence-based policy dialogue. This is essential to ensure reliable data are being used for prompt evidence-based decision-making and ensuring healthy living by the communities. We would also like to highlight that Maldives, with the support from WHO, is currently working on the formulation and publication of the Digital Health Architecture Blueprint to improve the health system. These initiatives would help to strengthen health system, quality-oriented health service delivery, and enable timely, accurate, and actionable data use for decision-making in future. On a final note, Maldives would like to encourage countries in our region to work collaboratively to ensure strengthening health systems considering the country priorities. Thank you, Chair.
Thank you. Now I give the floor to Bangladesh.
Honorable Chair, distinguished delegates, esteemed colleagues, on behalf of the Government of Bangladesh, I would like to thank WHO for bringing this important topic for discussion during 78th Regional Committee meeting of WHO-CR. Good health and well-being remain central to our national development priorities. As one of the most densely populated countries in the world, Bangladesh is committed to achieving universal health coverage and is actively engaged in the Sustainable Development Goal Global Action Plan, working in close collaboration with WHO and other global partners. We acknowledge that while 17 out of 32 health-related SDG indicators show progress, 12 remain stagnant and 3 face data-related challenges. Out of 2 indicators of universal health coverage, country is stagnant on the progress in service coverage index and, however, showing rising trend of financial hardship due to access to healthcare expenditure. A midterm evaluation of these indicators is currently underway with WHO's technical and financial support to identify challenges and policy gaps in accelerating progress towards achieving UHC and SDG. Honorable Chair, we are grateful to WHO for its continued assistance in producing the Health SDG Profile 2023 Bangladesh and in supporting the localization of SDG targets at divisional and district levels. This is helping us identify disparities and take timely and targeted corrective actions. Bangladesh has recently completed its Voluntary National Review 2025 with WHO support in reviewing the health section. We are also advancing key reforms as recommended by Health Sector Reform Commission. We appreciate WHO's support in drafting National Health Service Standards to ensure essential health services for all and expanding NCD corners at Upazila and district hospitals to ensure access to health services for emerging health needs related to NCDs. The government of Bangladesh, with support from WHO, has been revising its healthcare financing strategy with a strong focus on primary healthcare to accelerate progress towards universal health coverage. In parallel, the government has initiated the development of a UHC roadmap aligned with the ongoing health sector reforms that emphasize strengthening primary healthcare and updating the financing strategy. In addition, major steps have been taken to prepare a 5-year health sector plan, foster multi-sectoral collaboration through a health in all policies approach, and implement structural reforms to improve the management and delivery of primary health care. Efforts are also underway to build the capacity of health workers and expand access to essential medicines at public facilities, particularly at the primary care level. However, we continue to face significant challenges: the rising burden of non-communicable disease, mental health issue, and fragmented health systems, data gaps, infrastructure limitations, and reduced donor funding further hinder our progress. Looking forward to WHO's continued support in our priorities, such as strengthening monitoring and analysis frameworks for SDG localization, developing a dynamic dashboard for local level planning, and enhancing data integration and real-time monitoring using advancing technologies. We reaffirm our commitment to working closely with WHO and member states to accelerate progress towards SDG 3 and ensure health and well-being for all. Thank you, Chair.
Thank you, Bangladesh. Now I give the floor to Thailand, followed by Bhutan.
Honorable Chair, distinguished delegates, Thailand extends its gratitude to the Secretariat for the comprehensive annual report. We particularly commend the thematic focus on civil registration and vital statistics, or CRS, which is indeed the cornerstone of effective population health monitoring. We found that the report has highlighted significant progress of Southeast Asia region in areas like maternal and child health. However, it also presents a reality, as distinguished delegates from Bhutan has primarily noted that we are currently facing financial protection issue, which is the persistent burden of non-communicable diseases and a collective pace that needs to be accelerated to reach our USC goal. Chair, in addressing how to translate commitment into concrete action, Thailand believes the answer lies in prioritizing investment in integrated, inclusive, and robust health information systems. We would like to echo our distinguished delegates from India that having a resilient CRS allows for the generation of timely and reliable data, which is indispensable for equitable policy making. We also support the integration of primary healthcare in national plan for the inclusive pathway to tackle challenges. Therefore, we urge fellow member states to embed data system strengthening within broader health system reforms. This includes integrating CRS functions directly into health service delivery and leveraging digital technologies to make data actionable. Thailand strongly supports the extension of the regional CRS strategies and stands ready to facilitate cross-country learning, as suggested in the report, to collectively accelerate our progress towards USC and the SDGs. Thank you.
Thank you, Thailand. Now I give the floor to Nepal.
Thank you, Chair. Respected Chair, distinguished guests, and esteemed colleagues. Namaste and warm greetings from Nepal. Nepal reaffirms its strong commitment to achieving universal health coverage and advancing the health-related sustainable development goals. We recognize the importance of tracking our progress through the annual publication by the Secretariat, which offers a valuable snapshots of key indicators across member states. Over the past decade, Nepal's UHC service coverage index has arisen from 37 in 2010 to 54 in 2021. This progress reflects our dedication to expanding access to essential health services. We are proud of achieving in reproductive, maternal, newborn, and child health. Today, 91% of women use modern facility planning methods. 82% of children with acute respiratory infections are taken for care, and 80% of births are attended by the skilled health personnel. However, we acknowledge that financial protection remains a challenge. Out-of-pocket health spending continues to burden many families. In response, the Government of Nepal has taken bold policy steps. Our National Health Insurance Program now covers 25% of the population and is steadily expanding. We have rolled out a basic health services that includes 98 essential medicines free of charge to support frontline primary health care. Furthermore, our national health accounts are actively tracking health expenditures to guide evidence-based decision-makings. Finally, Nepal remains steadfast in its journey towards equitable, accessible, and quality health care for all. Thank you.
Thank you, distinguished delegates. I now invite Ms. Shahia Alimanik from the South Asian Association for Regional Cooperation to make a statement on their behalf.
Thank you, Mr. Chair. The region continues to make progress towards achieving universal health coverage and health-related sustainable development goals, with the UHC service coverage index improving from 47 in 2010 to 62 in 2021. However, financial protection remains a major concern, with 16.1% of the population facing catastrophic out-of-pocket health expenditures. While gains have been recorded in maternal and child health, immunization, and infectious disease control, significant gaps remain in non-communicable diseases, mental health, sanitation, and mortality data systems. Complementing the ongoing efforts, the South Asian Association for Regional Cooperation has played a critical role in addressing shared public health challenges. SAARC's regional strategy on HIV/AIDS and TB control continues to strengthen cross-border cooperation, surveillance, and joint TB/HIV collaborative activities are being scaled up with support from member states and technical partners. In collaboration with UNICEF, UNFPA, and WHO, SAARC's initiatives have focused on reducing adolescent pregnancies through regional knowledge sharing and improving access to adolescent-friendly health services. On nutrition and anemia, SAARC, in collaboration with UNICEF Rosa, organized a regional conference, Nourishing South Asia, Reducing Anemia in Adolescent Girls and Women in South Asia, here in Colombo in July. The regional conference highlighted the need for an agreed common comprehensive multi-sector regional strategy for anemia prevention, diagnosis, and management in South Asia with contextual adaptation across countries is needed. In this regard, SAARC is very pleased to inform about the establishment of the SAARC SAU Regional and Transdisciplinary Center for Precision Nutrition and Health at South Asian University in Delhi. Going forward, integrated efforts must focus on accelerating equity in service coverage, reducing financial hardship, and building resilient health systems. Stronger CRVS systems, enhanced health workforce capacities, and targeted investments in adolescent and reproductive health will be essential to meeting the 2030 targets. Thank you, Chair.
Thank you, Ms. Shahia. I now invite Dr. Raju Dakal from the International Society of Physical and Rehabilitation Medicine to make a statement on their behalf.
Good afternoon. This is Dr. Raju Dakal from Nepal on behalf of International Society of Physical and Rehabilitation Medicine and WHO CRO representative. My statement here Rehabilitation is an essential health strategy for achieving universal health coverage and Sustainable Development Goal 3. 1/3 of the world's populations are estimated to be living with health conditions that could benefit from rehabilitation. The Southeast Asia region accounts for almost 1/4 of these global needs, with an estimated 630 million people needing rehabilitation due to illness or injury. In its strategic regional framework for rehabilitation about to be launched, the WHO's Southeast Asia region has emphasized the importance of strengthening rehabilitation services to achieve universal health coverage by promoting access to quality care and integrating these services into primary health care and across all levels of health care, in line with the World Health Assembly Resolution 76.6 on strengthening rehabilitation in health system. Monitoring progress on UHC and health-related SDGs should integrate indicators on rehabilitation and assistive technology, recognizing their role in improving functioning, societal participation, and overall quality of life by decreasing health complications, hospital readmissions, and ultimately the long-term healthcare cost. The International Society of Physical and Rehabilitation Medicine, supported by the World Rehabilitation Alliance, urges member states to prioritize investing in quality rehabilitation services and skilled professionals at all levels of health pyramid, and to expand financial protection for rehabilitation, starting with high priority services and scaling up as resources allow. Thank you.
Thank you, Dr. Dakal. I now invite Dr. Kumundini Ranatunga from the World Federation of Societies of Anesthesiologists to make a statement on their behalf.
Thank you, Chair. The World Federation of Societies of Anesthesiologists represent over 500,000 anesthesiologists in 151 countries, including 10 national member societies in the Southeast Asian region. Evidence from World Health Assembly and the Southeast Asia resolutions confirms that effective anesthesia and surgical services are essential for achieving universal health coverage and SDG 3 targets. Yet, across Southeast Asia, millions still lack access to safe, timely, and affordable surgical care due to shortages of trained providers, limited infrastructure, and uneven distribution of services. Without stronger anesthesia and surgical systems, health systems remain incomplete and progress towards UHC will stall. Advancing UHC requires integrated emergency, critical, and operative care services within a primary healthcare approach. Anesthesiologists are uniquely positioned to support this vision. They work across all 3 service areas and care for patients along the entire pathway, from preoperative assessment to recovery and beyond. Their expertise makes them not only vital clinicians, but also essential leaders in designing, implementing effective people-centered services. We commend the prioritization of integrated systems and stronger workforce planning highlighted within this report. We urge member states to invest in anesthesia and surgical capacity, expand opportunities for continuing education, and incorporate safe surgery and anesthesia indicators into UHC monitoring frameworks. WFSA and our member societies stand ready to support governments in strengthening services and leadership capacity in alignment with WHO guidance. Chair, safe anesthesia and surgical care integrated into primary health care must be central to achieving health for all. Thank you.
Thank you, Dr. Ranatunga. I now invite Dr. Pubudu Sumanasekara from the Movendi International to make a statement on their behalf.
Thank you, Chair. Excellencies, distinguished delegates, and friends. We all share a common vision, a world where every person can live a healthy life with access to health care when it is needed. Yet this vision is under threat. Alcohol harm is a major barrier to achieving universal health coverage and the SDGs. Alcohol harm is a health issue. It burdens healthcare systems, fuels NCDs, injuries, and mental ill health, and drains household resources, leaving families poorer and communities less resilient. Alcohol harm is also a sustainable development issue. It undermines 15 of 17 SDGs, from poverty eradication and gender equality to quality education and economic development. Behind the statistics are millions of children growing up without food, books, or safety because of alcohol harm. Honorable Chair, we are deeply concerned that alcohol is omitted from the UHC and SDG progress report. This leaves a dangerous blind spot. The health system, especially primary health care, has a critical role to play in preventing and reducing alcohol harm. Fortunately, solutions exist. The WHO best buys on alcohol are proven cost-effective solutions with immediate positive effects. Among them, alcohol taxation is the single most powerful tool. It prevents harm, reduces cost, and generates sustainable revenue for health systems. The World Health Report already showed in 2010 that raising alcohol taxes to 40% of retail price in low-income countries could reduce alcohol consumption by more than 10% and more than triple revenues to nearly 40% of total health spending. Recent analysis show that every $1 invested in scaling up the alcohol policy best buys delivers a return of $9 in societal benefits. By raising alcohol taxes and improving other alcohol policy best buys, member states can create self-sustaining, equitable, and resilient health systems. This is smart economics and powerful catalyst for UHC and the SDGs. Thank you, Chair.
Thank you, Dr. Sumanasekara. I now invite Dr. Komal Kalha from the International Federation of Pharmaceutical Manufacturers and Associations to make a statement on their behalf.
Thank you, Chair. IFPMA, the International Federation of Pharmaceutical Manufacturers and Association, represents the leading research-based biopharmaceutical companies, as well as national and regional industry associations across all 5 continents. IFPMA welcomes the agenda items on primary healthcare and universal health coverage. Unlocking investment in primary care is critical if we are to build a stronger, preventive healthcare systems and make substantive progress in tackling the rising incidence of non-communicable diseases, including cancer, cardiovascular disease, and diabetes, as well as the burden of infectious disease and the associated threat of antimicrobial resistance. Research commissioned and published by IFPMA earlier this year demonstrates that in low and middle-income countries, an additional 1% of GDP investment in total public healthcare expenditure, where 40% is channeled towards cost-effective primary NCD healthcare interventions, could save close to 5 million lives each year. Building the necessary capacity and health workforce alongside investment in primary and secondary prevention can reduce hospitalization, lost productivity from premature deaths, and greatly relieve pressure on health systems. Improving awareness and uptake of essential and innovative medicines, vaccines, diagnostics, and medical devices, supported by appropriate health service delivery models, is key in achieving UHC and will be essential to improving population health and stronger healthcare systems. Our members continue to work to drive improved access to medicines and vaccines and work in partnership to strengthening healthcare systems to improve the lives of people around the world. And IFPMA remains committed to working as a constructive partner towards these goals. I thank you, Chair.
Thank you, Dr. Kalha. I now invite Dr. Manita Puyakurel from the NCD Alliance to make a statement on their behalf.
Thank you, Chair. The NCD Alliance and the SEER NCD Alliance commend regional progress on universal health coverage and health-related SDGs. Yet, we are concerned that major challenges persist in reducing the burden of NCDs and mental health conditions. Meanwhile, the Universal Health Coverage Service Coverage Index is not improving fast enough to reach the minimum essential global UHC HCI of 80 by 2030, and financial protection continues to deteriorate, with catastrophic spending rising, disproportionately affecting people living with NCDs. As member states gathered with the intention to fast-track efforts to reduce premature mortality from NCDs by 1/3 and provide access to mental health care for 150 million more people by 2030, at the 4th UN high-level meeting on NCDs and mental health, we urge governments to strengthen legislative, regulatory, and fiscal measures, including health taxes on tobacco, alcohol, sugary drinks, and unhealthy foods, and safeguard policymaking from industry interference. Ensure 80% of primary health facilities provide affordable NCD mental health medicines and technologies by investing 1.1 to 1.7 of gross national income while expanding financial protection to cut out-of-pocket costs. We also urge member states to strengthen NCD surveillance and monitoring, updating the WHO NCD Global Monitoring Framework, and embedding the NCD targets into broader development processes. Invest in training and retaining the frontline health workers for NCD prevention, screening, and management. Also, promote national air quality standard and integrate NCDs into emergency preparedness and climate adaptation strategies. Also, institutionalize social participation, ensuring people living with NCDs, youth, communities, and CSOs engage in policy design, implementation, and monitoring. The Share NCD Alliance is ready to work with WHO and governments to translate the high-level meeting commitments into measurable actions, ensuring the universal health coverage delivers on its promises for health for all. Thank you, Chair.
Thank you, Dr. Manita. I now invite the WHO Secretariat to respond to the observations made by the distinguished delegates.
Thanks, Chair. So the 70th session of WHO RC had mandated the RD to present an annual report on UHC and health-related SDGs as a substantive agenda until 2030. So it's so good that all the member states of the region made an intervention on this agenda, which reflects their commitment and interest on this agenda. It's very difficult to sum up all the points that have been highlighted, but all the countries have shared series of policy and programmatic interventions that have been made to advance progress on UHC and health-related SDGs, and have also highlighted the challenges. We notice that progress is not on track on UHC in most countries on the service coverage index, and certainly not on the financial protection side. Also, there are gaps in terms of several health-related SDGs, and the progress is not uniform across the countries of the region. We applaud the progress that countries have made and also highlighting the challenges. The thematic focus this year was progress in the decade for strengthening role of health sector in improving CRVS, and appreciate that all member states acknowledged and applauded inclusion of this thematic focus in this year's progress report. Key things that emerged in light of demographic and epidemiological transition was in terms of strengthening the PHC approach, which will be more equitable and efficient, and also in light of the change of disease burden towards NCDs. So another thing that was highlighted was in terms of addressing the challenge of financial protection and quality, and strengthening data systems, particularly CRVS, data-driven governance, sustained investments in digital interoperable health information CRVS systems. And thanks to all the partners and non-state actors for their intervention and highlighting critical challenges in certain areas. I've noted down the request from several member states in terms of WHO to continue to provide technical cooperation, capacity building, and facilitating knowledge exchange. We also take note of support for ICD-11 and MCCD, medical certification of cause of death, including verbal autopsy. And we have taken note of some observation, particularly from India, regarding adopting national data. So while WHO does recognize and values national data as a foundation for health statistics, we recognize that for global and regional monitoring and to address national data gaps, WHO applies internationally agreed upon evidence-based methods to produce comparable estimates across countries over time. So national data come from different sources, surveys, routine HIS, registries, etc. And they may vary in quality, coverage, periodicity, etc. To ensure consistency and comparability, we use a transparent estimation method where we compile all the available national data, adjust for data gaps, and apply standardized modeling and demographic inputs. Now, these estimates that are developed, including for UHC, are indeed, they undergo extensive country consultation before they are published, allowing member states to review and provide feedback. And WHO remains committed to supporting member states in strengthening health data systems and also capacities over time. There was a specific mention around financial protection estimates, about 6.7% and 17%. We will take it up offline in terms of explaining as to why the two data is at variance. I think that's broadly captures the thing, and WHO would continue to provide the requested technical cooperation, capacity building, and knowledge exchange support. Thank you.
Thank you. I invite WHO senior management for comments. Since you have no comments, thank you. Excellencies and distinguished delegates, I have the pleasure in inviting the Secretariat to launch a publication titled Monitoring Progress on UHC and Health-Related SDGs in the Southeast Asia Region 2025, which will be followed by a video launch of the Southeast Asia Health Financing Dashboard.
You can download this by scanning the QR code.
Introducing the Southeast Asia Region Health Financing Dashboard, a new tool to enable smarter decisions on health financing and investment. The dashboard brings together macrofiscal indicators and health expenditure trends and patterns for each member state. The dashboard amalgamates data from multiple sources. While primarily building upon the WHO Global Health Expenditure Database and UHC Global Monitoring Report, it also extracts selected data from the IMF World Economic Outlook and World Bank World Development Indicators databases. The regional database will be updated on the dashboard annually in December by CIRO and will continue to be accessible on the CIRO website. Designed to empower policymakers and researchers, this dashboard brings clarity to complex data, providing valuable analytical inputs for sustainable health financing in the region. Scan the QR code to access the dashboard.
Thank you. Distinguished delegates, this brings us to the end of this agenda item. Excellencies and distinguished delegates, let us take the agenda sub-item 8.2, that is expanding the corpus of the Southeast Asia Regional Health Emergency Funds. I call your attention to the working paper SEA/RC78/7. The Southeast Asia Regional Health Emergency Fund is an operational fund of Southeast Asia region established in 2008 to provide support to the health sector response of member states during emergencies. The regional committee session last year agreed to increase the corpus of the Southeast Asia Regional Health Emergency Fund to US $3 million to come into force from the 2026 to 2027 biennium, and to roll over unspent balances to the subsequent biennium, as well as to merge the response stream and preparedness streams for improved efficiency. Furthermore, the regional committee advised the Secretariat to consult working group of the fund to revise the policies and business rules of the fund. The Secretariat, during the intervening period, widely consulted and drafted revised policies and business rules for the Fund 2.0, which are annexed to the working paper. The working paper, along with the HLP recommendations, is now presented to the 78th session of the WHO Regional Committee for Southeast Asia for its consideration. Member states are requested to consider approving the revised policies and business rules for the Fund 2.0 and guide the Fund Working Group and Secretariat in developing a resource mobilization strategy 2.0. I now give the floor to the honorable delegates to make their comments and observations on the subject. I give the floor now to India.
Thank you, Chair. India understands that since its establishment in 2008, the Southeast Asia Regional Health Emergency Fund has served as a vital instrument of regional solidarity, enabling timely support to member states during the most critical initial phases of health emergencies. The Government of India appreciates the efforts of WHO in providing emergency financial support for 49 health emergencies across 10 countries in the Southeast Asia region in a time-bound manner. We also commend the Secretariat for its comprehensive analysis of the fund needs, utilization, and gaps under CIF. India takes note of the proposed revisions in the CIRHEF policies and business rules for CIRHEF 2.0. We welcome the Regional Committee's decision to increase its corpus to USD 3 million, beginning with the 2026-27 biennium, permitting the rollover of unspent balances and merging the response and preparedness streams. These reforms will enhance the fund's flexibility and responsiveness in an era marked by heightened health risks and climate-related emergencies. While these reforms are important steps, India wishes to highlight a few areas for careful consideration as we move forward. First, the proposed 20% earmarking for stockpiling and logistics could be better integrated within preparedness activities to provide greater flexibility in fund utilization. Second, it is essential to ensure that CIRHEF's resources are complementary and not duplicative of other financing mechanisms, particularly during public health emergencies of international concern and pandemics. Third, commodities assistance provided under CIRHEF must be acceptable and usable within national health systems of recipient member states. Lastly, the 33% ceiling on procurement of essential medical supplies and services may require reconsideration, particularly for high-burden emergencies where such expenditures constitute a substantial share of response cost. Chair, India reiterates its support for the CIRHEF 2.0 and is committed to working with WHO CRO and member states to ensure its success. We emphasize that CIRHEF's financial and operational mechanisms must be harmonized with evolving global health instruments, particularly the amended IHR 2005 and the pandemic agreement. Ensuring cross-communications between these frameworks will enhance coherence, prevent duplication, and facilitate optimal use of available resources. India seeks clarification on the proposed 6-month fund validity period for both response and preparedness allocations. Given that
the duration of recovery and preparedness activities can vary considerably across contexts. Further clarity on possible extensions or reprogramming mechanisms would be valuable to ensure optimal utilization of CRHEF resources. Further, India underscores the importance of ensuring clarity, transparency, and accountability in fund application, allocation criteria, and reporting mechanisms to uphold the principles of equity and trust that formed the foundation of CRHEF. Thank you.
Thank you, India. Now I give the floor to Bangladesh.
Honorable Chair, distinguished delegates, and esteemed colleagues. Bangladesh as a disaster-prone country deeply appreciates CRO management of the Southeast Asia Regional Health Emergency Fund, which has provided vital support during emergencies since 2008. Bangladesh has benefited from CRF during major events such as the Dhaka fire in 2010, Cyclone Mora in 2017, the forcibly displaced Myanmar national crisis during 2017 and 18, as well as severe flash flood and pox-related response in 2024. We strongly support the development of new emergency fund 2.0 policy aligned with the guidance of the regional committee. We welcome key enhancement, including increasing the fund ceiling to $400,000 and increasing the budget provision to $3 million for 26-27. We are also pleased that the fund now supports both emergency response and critical preparedness activities. The inclusion of a preparedness phase under this emergency fund is particularly valuable. This will enable countries like Bangladesh to strengthen essential capacities ahead of emergencies. Areas such as workforce training, simulation exercise, improved disease surveillance, and the stockpiling of essential medical supplies stand to benefit significantly. Mr. Chair, to further strengthen national engagement and coordination, we propose the inclusion of representatives from the Ministry of Finance and Ministry of Planning, alongside the Ministry of Health and Family Welfare, in this emergency fund-related process. Their participation would help facilitate domestic contribution and resource mobilizations for the fund. Finally, we kindly request the Emergency Fund Secretariat to leverage the growing interest and commitment of donors to secure additional support for the fund. Enhanced visibility and strategic advocacy will be essential to ensure its sustainability and effectiveness in the years ahead. Thank you very much.
Thank you, Bangladesh. Now I give the floor to Nepal.
Thank you, Chair. At the outset, I wish to extend Nepal's deep appreciation to the World Health Organization and the Regional Office for Southeast Asia for their steadfast support to member states through the Southeast Asia Regional Health Emergency Fund, CREF. This mechanism has been a lifeline for countries like ours, providing timely, flexible, and catalytic support during moments of greatest need. Nepal has directly benefited from CREF support at the critical junctures: the Kosi floods in 2008, the devastating earthquake in 2015, and the Jajarkot earthquake of 2030. In each instance, CREF enabled us to rapidly deliver life-saving health interventions, deploy supplies and teams, and sustain essential services when our national systems were most strained. During the Jajarkot earthquake response, for example, CREF support combined with the WHO's contingency fund for emergencies and additional mobilization helped vaccinate over 600,000 people against measles, rubella, and typhoid. Deploy solar-powered systems to health facilities and establish temporary sites serving thousands. Such impact underscores the unique value of this fund. Nepal has also demonstrated its commitment to SHERIF. In 2024, we contributed Nepali rupees 1.5 million through our Ministry of Health and Population's annual budget, despite competing national priorities. This reflects our belief that regional solidarity and shared responsibility are essential for sustainable preparedness and response. We welcome and approve the SHERIF 2.0 policy paper. Chair, the proposed expansion of the corpus to $3 million, the merging of preparedness and response streams, and the inclusion of stockpiling provisions represent strategic and forward-looking reforms. Nepal particularly values the emphasis on readiness activities, rapid release of funds, and principles of transparency, accountability, and flexibility. We also support the innovative approaches outlined for resource mobilization, including leveraging regional partnerships, engaging with development banks and philanthropies, and exploring voluntary contributions from member states. Nepal welcomes the measures for strengthening monitoring and evaluation, introducing real-time financial dashboards, and documenting regional success stories to enhance accountability and learning. At the last, Nepal reiterates its firm support to SHERIF 2.0. We stand ready to contribute actively to its governance, mobilization, and implementation so that together as a region, we can ensure that no country stands alone in the face of emergencies. SHERIF has proven its worth as a beacon of regional solidarity with SHERIF 2.0, and it will become even stronger. Thank you.
Thank you, Nepal. Now I give the floor to Thailand.
Thank you, Chair. Thailand wishes to express our appreciation to the Secretariat and all member states for their continued dedication in strengthening the Southeast Asia Regional Health Emergency Fund through the revised policies and business rules under CRF 2.0. The expansion of the corpus to $3 million alongside with the streamlined operation mechanism reflect the collective determination of our region to ensure that timely and flexible financial support is available for member states in a time of crisis. This is a clear demonstration of our shared solidarity to safeguard the health and well-being of our people. Thailand strongly believes that CRF should serve as a mechanism for rapid response and also as a strategic instrument to advance regional preparedness and capacity building. Strengthening this dimension will ensure our systems are resilient, proactive, and well-equipped to manage emerging threats before they escalate into a full-scale emergency. Thailand fully supports the endorsement of the policy and business rules for CRF 2.0. And we encourage continued effort to establish a sustainable resource mobilization strategy through active engagement with partners and donors. Thailand reaffirms our unwavering commitment to work closely with the Secretariat and fellow member states in further strengthening CRF, as it is a cornerstone mechanism for preparedness and response to health emergency in our region. Thank you, Chair.
Thank you, Thailand. Now I give the floor to Sri Lanka.
Thank you, Chair. Sri Lanka thanks the Regional Director, the Regional Emergency Director, and the WHO CRO for their continued leadership in advancing the Southeast Asia Regional Health Emergency Fund, which has been a lifeline for our region since its establishment. Sri Lanka has directly benefited from CRF support in responding to floods, landslides, internal displacement, and outbreaks. We have also benefited from the preparedness stream, which has strengthened our National Health Emergency Operations Center and supported the establishment of subnational health emergency operation centers. These interventions have been critical in enhancing our national readiness and response capacities. We recognize the extensive work carried out by the Secretariat in close consultation with member states to develop the policy framework for CRF 2.0. The revised policy addresses current regional needs while ensuring that the fund continues to maintain its original purpose of supporting life-saving emergency health response. At the same time, we welcome the expanded scope to strengthen preparedness, readiness, and stockpiling of critical supplies. Sri Lanka also acknowledges the importance of resource mobilization to sustain CRF 2.0. Given the growing frequency and scale of health emergencies, securing adequate resources and building strong partnerships will be essential to operationalize the expanded fund from 2026 onwards. In conclusion, Sri Lanka expresses its strong support for the CRF 2.0 policy document and reaffirms its commitment to regional solidarity in strengthening emergency response and preparedness. Thank you.
Thank you, Sri Lanka. Now I give the floor to the Maldives.
Thank you, Chair. Maldives appreciates the Secretariat for presenting the revised policy and business rules for CRF 2.0 and acknowledge the extensive consultations undertaken with member states and partners. We recall that CRF has been a lifeline for our region since its establishment in 2008, supporting 49 emergencies across 10 countries and dispersing over $8 million US. For the Maldives, CRF support during the COVID-19 pandemic strengthened our Health Emergency Operations Center, rapid response teams, disease surveillance, and PPE stockpile critical measures that protected health workers and saved lives. We welcome the expansion of the corpus to $3 million US from the 2026-2027 biennium, the merger of the response and preparedness streams, and the decisions to roll over unspent balances, ensuring greater efficiency, flexibility, and sustainability. Importantly, CRF 2.0 provides clarity on the scope of its support. We also appreciate the strengthened eligibility criteria, including national or subnational declarations, official requests for assistance, public health of emergencies of international concerns or pandemics, imminent disaster forecast, IHR MEF recommendations, and impending stock out of life-saving supplies. These provisions ensure timely, transparent, and equitable access. Maldives further supports the proposed allocation structure and the enhanced ceiling of $400,000 per event in the 2 tranches. Maldives reaffirms our strong support for CRF 2.0. We joined the call to review and recommend approval of the revised policy and business rules. We call upon all member states to contribute actively through financial and in-kind contributions, as well as advocacy with partners and donors for the sustainability of this vital mechanism. For a small island state like the Maldives, CRF is not just a fund, it is a symbol of solidarity, resilience, and collective responsibility in the face of shared threats. Thank you, Chair.
Thank you, Maldives. Now I give the floor to Bhutan.
Thank you, Chair. At the outset, Bhutan wishes to commend the Sheriff Working Group and WHO CRO for their tireless efforts in strengthening the Southeast Asia Regional Emergency Fund. We acknowledge the substantial progress made in transforming Sheriff into a more flexible, responsive and sustainable financing instrument for our region. Bhutan has actively participated in all working group deliberations towards developing the policy framework. We strongly support the expansion of its scope and the increase of corpus from US 1 million to 3 million as endorsed during the 14th meeting of the working group in May 2025. The proposed integration of preparedness and response teams will undoubtedly enhance both the timeliness of the response and readiness for evolving risk. To ensure Sheriff's sustainability, Bhutan is exploring ways to contribute meaningfully to the fund. And we stand alongside with other member states in advocating for greater engagement with potential donors and partners. We also remain committed to working with WHO, CRO, and member states on development of robust resource mobilization strategy. Further, Bhutan wishes to reiterate the submissions made during the last regional committee meeting in New Delhi, requesting support from member states in developing country-level health financing strategies for emergencies. In conclusion, Bhutan strongly supports the adoption of Sheriff 2.0. Sheriff is not only a financing mechanism, it is the very backbone of our regional health security and resilience. Thank you, Chair.
Thank you, Bhutan. Now I give the floor to Timor-Leste.
Thank you, Chair. On behalf of the Government of Ministry of Health of Timor-Leste, I wish to express our sincere appreciation to WHO and Southeast Asia Region Health Emergency Fund to their continuous and timely support. Over the past year, CRF have been a critical lifeline for Timor-Leste in responding to health emergency, including COVID-19, dengue outbreak, and recent climate-related events such as floods and landslide. This rapid assistance enabled our ministry to deliver essential medical supplies, restore the health services, and strengthen our capacity for emergency preparedness and response. The fund not only provides immediate relief, but also support long-term resilience, helping us build detection and response. Timor-Leste remains fully committed to contribute to the sustainability of Sheriff and working with our region partners to ensure no country is left behind. Thank you very much.
Thank you, distinguished delegates. I now invite the WHO Secretariat to respond to the observations made by the distinguished delegates.
Thank you, Chair. Thanks very much, Your Excellencies, distinguished delegates from the member states. Thank you, all the countries, for your generous support and concurrence in principle for the business rules and policies for the expansion of CRF that was endorsed by the last regional committee. We have taken note of all the comments and observations made by the member states. Most of the member states agreed to support the resource mobilization strategies for mobilizing funds for the CRF, including participation in the CRF working group, that is the governing body mechanism for the management of CRF. We sincerely thank countries who have made contributions to CRF, including India, Thailand, Timor-Leste, and most recently Nepal. We sincerely appreciate, and we hope that many more member states will contribute to make CRF a sustainable regional health, security, and solidarity purpose, because in the current times of financial constraints for overall health sector and the particularly health security, it's very important that CRF-like mechanism, which has proven in our region for more than last 15 years, gets fully supported by the member states themselves. To address some of the specific points raised by some of the member states, we will make sure that the CRF is complementary and not duplicating, particularly in cases of public health emergencies of international concern and pandemic, when there is a lot of funds flowing, and we will ensure that CRF is complementary. Also, India's point about mobilizing only those kind of supplies, medicines, etc., to the countries where they are accepted by the national health systems of those particular countries. So we take note of that and we'll make sure about this. Regarding a couple of other points that India mentioned, of course all other countries mentioned about the importance of accountability, reporting, monitoring. So just wanted to again update the distinguished delegates that CRF has a live website where all the contributions, all the funds used for different emergencies, the criteria, they are updated on regular basis. India's point about 6 months fund validity, which is important. This is the revision in the business rules is based on our experience of managing or supporting management of CRF for last 15, 17 years. And usually in the emergencies, the funds are utilized quickly, and so we have kept a benchmark of 6 months, but we can surely consider a joint request by the government supported by the WHO country office representative in case of any exceptional extension. You know, we always do no cost extension, so we can consider that. That should not be an issue at all. Similarly, 20% stock need to be integrated with the preparedness. Yes, basically the stocks are for preparedness and readiness, for seasonal outbreaks or for weather events. So that also I don't see any exclusivity there. And the 33% cap in the procurement, again this is a guidance and not a limitation, but I fully agree that in situations like COVID pandemic, where most of the funds were required for procuring several items, medicines, vaccines, diagnostics, and so 33% cap in the procurement should not be a limiting factor. And so I will propose a kind of an asterisk or a sentence just to explicitly identify or mention that, so that concern is well addressed. Bangladesh point about resource mobilization and also the support from the domestic resource mobilization is highly welcome. We sincerely hope that the member states will make regular contributions to CRF to make it sustainable. Accountability like issues we will fully address, and Bhutan's point that they also made earlier about supporting health emergency financing mechanism at the country level, that could be this beyond the scope of the CRF, but we will work with the health system department and provide required technical assistance for any countries that request for health emergency financing mechanism at the national level. Thank you again all the member states. We really are looking forward to implement the CRF 2.0 from the next biennium, full-fledged implementation. We expect your full support and cooperation. Thank you, and I would request, with the permission of Chair, DPM for his advice.
Thank you, Chair. And just a few things to add from Dr. Nilech. CRF is the testament of our own solidarity, and it is a model for many other mechanisms to the other. I would like to raise on the issue of sustainability of CRF. Sustainability of CRF, as you know, rely on three functions, three pillars. Number one is resource availability. For CRF, it is a mechanism for health security for the region. It is better to have and not use than when you want to use, you do not have. So that is the security. We have come to many scenarios, including at the moment, that there are demand, but we are running out of all funds. So the CRF 2.0 come to serve that function, that we expand the envelope of this site. But we relied on resource mobilization both from member state, if we have ownership, both from member state and from partners. Number two, we have to fit for purpose for CRF, fit for purpose, fit to evolving context, evolving demand. So we take note on your recommendation and your guidance that CRF cannot duplicate the other financing mechanism for health emergency available. It has to be catalyst to other functions, and it should fit very well with IHR and pandemic agreement that is ongoing discussion. It should fit with evolving demand. So you're talking, I think Bangladesh talked about the need to do the simulation exercise, the health emergency health workforce, that it need to address that part. And the third very important is this governance part. So of course we are talking about CRF 2.0, but CRF 2.0 has to be a learning curve for all of us. If 20% is not fit, what is the right proportion in the future? We need to come back to discuss about how long we can procure this essential medicine and that part. But most of all, it is member state ownership that is the most important for the long run for CRF. With that, thank you very much.
Thank you. Excellencies and distinguished delegates, I have the pleasure in inviting the Secretariat to launch a publication titled Southeast Asia Regional Health Emergency Workforce Strategy 2025 to 2030. Thank you. Distinguished delegates, this brings us to the end of this agenda item. Excellencies and distinguished delegates, it's time for some physical activity. May I request the Secretariat to lead us through the 3-minute physical activity break.
Thank you, Chair. So now
Thank you very much.
for better visibility, the master
Nice
will
to
go
be
up.
here once again. I'm Dr. Rupika Fonseca, consultant, yoga clinic at National Ayurveda Hospital, Colombo, Sri Lanka. Today we are going to do, yesterday we did breathing practice. Today we are going to do breathing practice plus stretching. Before that, I'd like to give some idea about, in Ayurveda, health is defined as mental, physical, social, and spiritual well-being. So yoga plays a key role in achieving all those 4 parts. So now you can all join together to practice this. First, in yoga, you have to concentrate on your body and your breathing practice through the mind. There are triangles, that physical part, mental part, and the breath. All together, there is a good coordination. So now we are going to do our physical practice first. You can do with us. Okay? Keep your hands interlacing your fingers and keep both hands together over the chest. Then now slowly stretch, fully stretch your hands and turn the other side. Now take up slowly up to the overhead. Now you can look at your hands and again slowly take your hands in front of your chest, then turn the side and slowly come to the chest. Okay, once again concentrate on the physical movement. Now start. Slowly stretch your both hands in front of your chest now. Now turn the side and slowly bring up and up to the overhead. Now you can look your hands and again slowly come to the chest level and turn the other side and come to the chest level. That is only the physical part. Now we are at the breathing practice in this. So you have to more concentrate on that, because in practicing this you may not concentrate altogether physical and breathing part. Now I will describe the way this is happening. Please listen to me and concentrate. Now keep your hands over the chest, but here now I am inhaling slowly while I am stretching my hands. As you fully stretch, now you take a deep breath, fully breath. Now hold your breath and turn your hand other side. Now you are going to release your breath slowly until you get totally upward over the head. Now you got fully breath, fully expand your lungs. Now slowly while exhaling, come to the chest level and turn the side. Slowly come to the chest level as you fully exhale. Concentrate more. I'll give some guidelines for the second time. First, you have to keep your hands over the chest. Now, with inhalation part and fully stretch of the hands. Okay? Now, while holding your breath, turn the other side, your hands. Now, while exhaling slowly, take your hands up and over the head. You can feel, yeah, now fully exhale. Now take a deep breath up to the chest level, then turn the other side, then slowly exhaling until when you touch your chest, you have fully exhaled. Because in yoga, there is a triangle: body, mind, and physical part. Because that exercises, we don't concentrate on our breath. Okay? But each and every practice of yoga, you have to concentrate on your mind, because this practice is very good for the elderly people, because we know nowadays that the elderly people suffering from dementia, depression, especially they can't concentrate in present moment, and there is no flexibility of the body. So yoga plays a key role in that our physical parts improve, and as well as our mind relaxation, and we can achieve our good health. So can we practice once again? Because please practice this daily you can concern, because you are the people who work for long period with laptops and writing and everything, because your head movements are not very effective. Most people suffering from cervical spondylosis like that. So it's very good because we don't practice that stretching our neck. So again, let's together we do this practice again 3 times. Keep your hands over the chest. Now concentrate your mind over the physical movement as well as breath. Slowly inhale. While you inhaling, fully stretch your hands. Now that hands are over the against the chest. Now concentrate over that. Breath holding and turn the side. Now slowly exhaling. Take your hands up and look at. Now again, take a slowly inhale and come to the maximum level. Now hold your breath and turn the hand other side and slowly exhaling, come to the chest level. Okay. And lastly, I want to make you aware, nowadays we know that school curriculum is added that yoga as that Surya Namaskara included in school syllabus, but it restricted to the context, because not practicing only for the knowledge. But if we practice Surya Namaskara and meditation, that pranayama, day-to-day life for 15 minutes even for school children, they become very healthy. Because nowadays we have identified school children suffering from scoliosis, like that skeletal problems, as well as they are very stressful people, tension, more agitative persons. So they are the vulnerable people because they are the people getting our future. So if we practice yoga in school period for the first 15 minutes, I think it's a very beneficial decision in our future. Thank you very much. Okay.
Thank you all for your participation. Let us resume the business session. Excellencies and distinguished delegates, let us continue our deliberations and take the third sub-item, 8.3, aligning regional policy actions with the global commitments, accelerating the fight against AMR in the WHO Southeast Asia region. Please refer to the working paper SEA/RC78/8. You will agree that antimicrobial resistance is a major threat to global public health with high mortality and significant socio-economic burden as consequences. Member states of the WHO Southeast Asia region have demonstrated early and strong political commitment to address AMR. Addressing the complex public health threat of AMR requires coordination across several sectors and stakeholders, spanning human health and animal health to agriculture and environment. Recent global and regional milestones, such as UN General Assembly's political declaration on antimicrobial resistance, September 2025, New York, the Asia-Pacific Ministerial AMR meeting, Jeddah Ministerial Commitment, and Tokyo AMR on Health Conference have created renewed momentum and opportunities for action. Leadership and ownership by member states is crucial to ensure developing costing, financing, implementing, and monitoring interventions to address antimicrobial resistance, including their national action plans on AMR. The WHO Regional Office, in consultation with the AMR focal points in member states, has drafted a regional roadmap to accelerate actions on AMR in the region. The working paper, the regional roadmap, along with the HLP recommendations, are now presented to the 78th session of the WHO Regional Committee for Southeast Asia region for its consideration. I now give the floor to the honorable delegates to make their comments and observations on the subject. Nepal.
Respected Chair, distinguished delegates, and esteemed colleagues. Antimicrobial resistance, AMR, poses a serious and growing public health threat. In 2019 alone, Nepal recorded an estimated 6,400 deaths directly attributable to AMR and 23,200 deaths associated with AMR, a burden higher than deaths from neoplasms, respiratory infections, and tuberculosis. Digestive diseases, maternal and neonatal disorders, and diabetes and kidney diseases. The government of Nepal recognizes AMR as a critical public health challenge. Our National Health Policy 2019, Nepal Health Sector Strategy 2015 to 2020, and One Health Strategy 2019 identify AMR as a priority issue requiring a One Health approach. Furthermore, Nepal's 16th National Plan, that is 2024-25 to 2028-29, highlights AMR as an area of urgent attention. To address this, Nepal has developed the National Plan, Action Plan or AMR 2024 to 2028, aligned with the Global Action Plan, providing a policy framework to guide national AMR containment efforts. Implementation is underway with designated focal agencies, a multi-sectoral coordination mechanism that is called National Steering Committee, Technical Working Committees, and Thematic Working Groups. And federal and provincial budget allocations, though modest at this stage. Nepal is now in its second year of NAP/AMR implementations. There are some key initiatives that include surveillance and monitoring. Nepal has a national AMR surveillance system with designated reference and network laboratories and has reported data annually to WHO GLASS platform since 2019. And next one, global reporting. Nepal has participated in the TRACSS survey every year since 2019, monitoring national response to AMR. Next, capacity building. National guidelines and protocols have been developed, including the National Antimicrobial Treatment Guideline, National Protocol for AMR Surveillance, National Guideline for Infection Prevention and Control, and updated essential medicines and diagnostics lists. Training and sensitization of medical doctors and health professionals on rational antimicrobial use and hospital antimicrobial stewardship programs are ongoing. Chair, there is also one more point, awareness and education. On that, AMR awareness campaigns target policymakers, professionals, media, and communities. Efforts are to integrate AMR content into school and professional curricula. Excellencies, while progress has been made, the burden of AMR continues to rise. Nepal is committed to the targets of 2024 UNGA high-level meeting on AMR and recognizes the need for stronger national and regional action. This requires ensuring affordable access to antimicrobials, vaccines, and diagnostics, improving WASH and infection prevention and control in health facilities, promoting science, research, and innovation, including R&D for new tools, strengthening civil society engagement and cross-country learning, and addressing inequalities and ensuring transparent monitoring and reporting. And to maximize collective efforts, Nepal proposes a regional resolution on AMR and looks forward to the commitment of all SEAR member states towards its adoption and implementation in alignment with the regional roadmap on AMR. Lastly, Nepal remains committed to working closely with WHO and partners to accelerate the implementation of our national action plan and to strengthen regional collaboration to address this urgent threat. Thank you.
Thank you, Nepal. Now I give the floor to Bhutan.
Thank you, Chair. Bhutan recognizes the grave threat that antimicrobial resistance poses to human and animal health, food systems, and the environment. We commit to align ourselves with global and regional initiatives to tackle this growing challenge through a coordinated approach. The impact of AMR is staggering, and particularly a matter of concern for the low and middle-income countries, thus demanding our sustained efforts by all stakeholders. Acknowledging the shared sense of urgency in tackling AMR, Bhutan has taken significant actions. An interministerial coordination for One Health mechanism has been established to strengthen governance and coordination across the key sectors. High-level policy dialogues have been organized to generate political buy-in, create awareness of AMR's impact, and garner stakeholder support. Bhutan has successfully designed and implemented its national strategy and action plan to combat AMR, aligning with the global and shared regional strategies and plans. We continue to promote rational use of antimicrobials, strengthen infection prevention and control, and support regulatory enforcement. Through the international donor support, Bhutan has significantly strengthened laboratory capacity for AMR monitoring and surveillance. Surveillance systems now capture data across sectors, helping inform evidence-based policy decisions. Bhutan has actively participated in regional and global AMR milestones and forums, and is committed to knowledge sharing, cross-border cooperation, and regional solidarity. Bhutan appreciates the regional roadmap to accelerate actions on AMR and supports the proposal for a regional resolution. We strongly believe that the roadmap will provide a clear direction for the region, and the resolution will reinforce regional collaboration, ensuring a sustained momentum towards combating the challenges posed by AMR. Thank you.
Thank you, Bhutan. Now I give the floor to Bangladesh.
Honorable Chair, Bangladesh recognizes antimicrobial resistance as a major public health, economic, and development challenge that threatens progress towards universal health coverage and SDG. In 2019 alone, Bangladesh experienced about 26,000 deaths directly attributable to AMR and nearly 100,000 deaths associated with it, highlighting the urgency of our collective response. Bangladesh has taken important steps to address this challenge. we have endorsed and costed the National Strategy and Action Plan for AMR Containment 2023 to 2028 and established an active One Health coordination platform. AMR and antimicrobial consumption surveillance is being conducted regularly with data reported to global platforms. Antimicrobial stewardship AMS program have been initiated in several hospitals and farms. National guidelines developed, an awareness and capacity building initiative undertaken for healthcare professionals and other stakeholders. Mr. Chair, despite these advances, significant challenges remain. These include the widespread sale of antimicrobials without prescription, irrational antibiotic use in healthcare facilities, high rates of hospital-acquired infections due to inadequate infection prevention and control, and environmental contamination from untreated waste. Sustained financing and stronger enforcement of regulations are essential to secure progress. Looking ahead, Bangladesh is committed to ensuring that all public and private hospitals establish effective infection prevention and control and AMS programs, strengthening enforcement of prescription-only sales of antimicrobials and operationalizing regulations for waste management across health, agriculture, and aquaculture. We will also prioritize interoperable One Health surveillance systems, regular multi-sectoral coordination, and integration of AMR awareness into medical, nursing, and school curriculum. Importantly, we are working to secure sustainable domestic financing by including AMR activities in the national budget. Mr. Chair, Bangladesh reaffirms its strong commitment to the global and regional AMR targets, and we look forward to working with member states, the regional office, and partners to accelerate collective action against this silent pandemic. Thank you, Mr. Chair.
Thank you, Bangladesh. Now I give the floor to India.
Thank you, Chair. India recognizes AMR as a formidable and growing public health threat globally, posing profound health economic risks, and aligns itself resolutely with the collective efforts to accelerate the fight against AMR within the WHO region and globally. Understanding the magnitude of this public health challenge, India formulated a comprehensive policy and surveillance framework which led to the launch of India's National Action Plan on AMR in 2017 in alignment with the Global Action Plan. Chair, building upon the lessons learned from the first National Action Plan, the Government of India has developed the National Action Plan on AMR 2025 to 2029, strengthening laboratory capacities to promote evidence-based antimicrobial use and ensuring the generation of high-quality AMR surveillance data are among the plan's core objectives. Chair, India welcomes and fully supports the regional roadmap to accelerate action on AMR in the human health sector in the Southeast Asia region 2025-30, as it aligns with our national priorities and commitment to control AMR. We believe that prudent and responsible use of antimicrobials along with robust infection prevention control measures in communities, hospitals, and long-term care facilities is essential to curb the emergence and re-emergence and spread of AMR. As highlighted in the regional roadmap, limited public awareness remains one of the major challenges in AMR containment in our region. To address this, India advocates for intensified information, education, and communication coupled with targeted behavior change communication strategies implemented particularly through grassroots health workers to raise awareness about rational use of antibiotics among the general public. We also encourage and urge all member states to consider making the mandatory display of antibiotic policy and standard treatment guidelines in local languages at all primary health centers and community pharmacies to promote appropriate use of antibiotics. Chair, we would like to also draw your attention to the need for technical data accuracy in AMR surveillance reporting. Surveillance data should reflect the magnitude of resistance rather than susceptibility. ensuring uniformity in data presentation across member states for comparability and consistency. Chair, India endorses the draft resolution of WHO Regional Committee for the Southeast Asia region, RC78, proposed by Nepal, and reaffirms its unwavering commitment to reducing the impact of AMR by 2030. Studies referenced in the WHO report estimate that up to 92 million deaths can potentially be averted globally between 2025 and 2050 through improved management of severe infections and better access to effective antibiotics. This calls for our collective action through a whole of government, whole of society approach to prevent AMR from becoming the next public health crisis and to eliminate this threat before 2015 from our region. Thank you.
Thank you, India. Now I give the floor to Timor-Leste.
Thank you, Chair. We note with a deep concern that IMR remain a major global health threat, responsible for an estimated 4.7 million deaths in 2021, with over half occurring in Asia-Pacific region. The economic impacts equally alarming, with the potential of healthcare costs exceeding 400 billion annually. Despite the strong commitment made since Jaipur Declaration, the 2016 Tokyo meeting, but progress in implementing remains uneven. The main challenge persists. Timor-Leste welcomed proposed regional roadmap to accelerate IMR action 2025 to 2030 and support its alignment with World Health Assembly 77 and the recent UN General Assembly political declaration on IMR. This instrument provides a clear global target to reduce IMR related to death by 10% and ensure 70% of antibiotic use from the WHO access group and strengthen national laboratory capacity by 2030. We urge the member state to strengthen multi-sectorial One Health collaboration, update and implement national IMR action plan. Surveillance and data sharing must be scaled up through GLASS, while antimicrobial stewardship, infection prevention and public awareness require renewed attention. Timor-Leste also calls for stronger regulation of antimicrobial use, particularly in veterinary sector, and for investment in research, innovation, and capacity building to accelerate equitable access to quality diagnostic vaccine and antimicrobials. Finally, we encourage WHO to continue to provide technical and financial support, strengthen quadripartite collaboration, and mobilize additional resources to sustain IMR commitment effort across region. Together, through the shared responsibility and sustainable action, we can protect the effectiveness of antimicrobials and secure the health of future generations. Thank you.
Thank you. Now I give the floor to DPR Korea.
Thank you, Chair. DPR Korea appreciates the active initiative WHO for combating AMR at all levels and welcomes the development of a regional roadmap to accelerate actions on AMR in the human health sector in the region 2025-2030. DPR Korea has already implemented National Action Plan on AMR 2022-2024 developed in line with the Global Action Plan, and now is at the stage of developing the National Action Plan on AMR 2025-2027. DPR Korea has been enrolled in Global AMR and Use Surveillance System in 2018, and since then has been submitting the report on the Tracking AMR Country Self-Assessment Survey every year. And in 2025, the National AMR Surveillance data was submitted to WHO. Recently, with the various conditions due to the global pandemic crisis and funding insufficiency, WHO's support has not been implemented efficiently in many areas, including AMR, and many developing countries are facing difficulties in implementing National Action Plan on AMR, as the qualified diagnosis of the infection for the AMR control and the UHC for its adequate treatment is to be ensured only with a huge financial and logistic support. In this regard, we consider that the good quality laboratory services and diagnostic stewardship and the development of the evidence-based treatment guidelines and programs for antimicrobial stewardship could be the priorities in the draft of the regional roadmap. For this, we would like to suggest the necessity of the development for the cost-effective and rapid antibiotic susceptibility testing and the guideline for the common pathogen treatment in the region, which is accessible at the primary healthcare facilities, as well as to increase the investment in the research for widely applying the traditional medicine to the prevention and treatment of the infections. Thank you.
Thank you. Now I give the floor to the Maldives.
Thank you, Chair. The Maldives commends the WHO Southeast Asia Regional Office for its leadership in developing the regional roadmap to accelerate actions on AMR. The inclusive consultation process demonstrates strong regional commitment to addressing this global public health threat through a One Health approach. We also acknowledge the Secretariat for preparing a comprehensive working paper that aligns regional priorities with global milestones, including the Jeddah Ministerial Declaration and the Tokyo AMR One Health Conference. Chair, over the past year, the Maldives has strengthened its national AMR response. In December 2024, we endorsed and began implementing the second National Action Plan on AMR 24-29, developed through broad multi-sectoral consultation and informed by lessons from the first plan. The updated plan emphasizes strengthened governance and legal structure with multi-sectoral coordination for a One Health response. The program is governed by a high-level multi-sectoral committee of cabinet ministers and guided by a national multi-sectoral committee on AMR, ensuring political ownership, policy coherence, and accountability. We also have established a national AMR surveillance system aligned with international standards, a national reporting mechanism to support evidence-based decisions, and updated the National Essentials Medicine List in line with WHO aware categorization to promote rational antimicrobial use. Despite these achievements, implementation of the National Action Plan faces constraints due to limited domestic and international funding, affecting the scale and sustainability of interventions. Expanding the surveillance beyond human health, strengthening laboratory capacity, regulating antimicrobial use, and implementing national antimicrobial consumption monitoring remains critical priorities. Looking ahead, the Maldives emphasizes the importance of regional collaboration. Shared learning, capacity building initiatives, pooled procurement, and continued technical support from WHO and partners will enable small island and low resource countries to sustain progress and strengthen resilience against AMR. The Maldives remains committed to working with member states to safeguard the effectiveness of antimicrobials and protect the health of current and future generations. Thank you, Chair.
Thank you. Now I give the floor to Sri Lanka.
Thank you, Chair. I thank WHO CRO for preparing the regional roadmap on antimicrobial resistance. We also commend Nepal for the leadership in proposing a regional resolution. Antimicrobial resistance continue to threaten our health system, food security, and economic stability. Sri Lanka successfully implemented the first National Action Plan 2017 to 2022 and is now advancing the National Strategic Plan on AMR 2023 to 2028 with a costed operational plan 2024-2025. This plan introduces governance and environmental safety as new pillars complementing the global strategic objectives. We have established a multi-sectoral coordination mechanism spanning human health, animal fisheries, agriculture, and the environment. Sri Lanka actively contributes to GLAS and INFARM, maintain sentinel sites, and have strengthened inspection prevention, wash standards, and stewardship policies. Yet, challenges persist, especially in sustainable financing, community-level enforcement, and laboratory capacity at primary healthcare level. Sri Lanka strongly supports the Regional Roadmap 2025 to 2030 proposed by Nepal to accelerate action on AMR in the human health sector in the Southeast Asian regions 2025 to 2030. It provides a people-centered, system-integrated approach that aligns AMR intervention with universal health coverage, primary health care, and pandemic preparedness. We endorse the call for increased domestic financing and stronger regulatory frameworks alongside regional cooperation for surveillance, innovation, and equitable access to diagnostics and medicine. Sri Lanka remains committed to addressing sustainable financing challenges while leveraging its strong public health traditions and surveillance network. As a regional knowledge hub, Sri Lanka aims to foster collaborations across South Asia under the One Health framework. The country pledged to work closely with member states, WHO, cooperative partners to strengthen collective response, endorsing the regional roadmap and resolution to combat antimicrobial resistance. Thank you.
Thank you. Now I give the floor to Thailand.
Thank you, Chair. Thailand welcomed the regional roadmap on AMR developed by WHO in consultation with member states. Thailand would like to underscore 3 main points. First, we recognize that the AMR is a growing threat to public health, affecting the socio-economic system and eroding the health security of our region. To respond and tackle effectively, Thailand is committed to strengthen governance as well as monitoring and evaluation system. We will continue to collaborate and promote capacity building activities at the national, regional, and global levels. Second, we have realized that the importance of cross-sectoral and multi-sectoral cooperation should exist. Tackling AMR requires strong partnership between human health, animal health, and environmental sector. Thailand supports the One Health approach as a foundation for sustainable action. Third, Thailand recognizes the critical intersection of universal health coverage and AMR in achieving sustainable health system. As indicated in the regional roadmap, UHC ensure equitable access to essential health services, including antimicrobials, while robust AMR strategy safeguard the effectiveness of this treatment. To strengthen this synergy, we enhance AMR surveillance system, invest in infection prevention and control, and promote antimicrobial stewardship. Our aim is to reduce morbidity caused by AMR by 10% by 2027, as indicated in our second National Action Plan on AMR. Chair, Thailand reiterates our strong commitment to join hands and stand ready to work with all member states and partners to accelerate progress and protect our region from the threat of AMR in our region. Thank you, Chair.
Thank you, distinguished delegates. I now invite Dr. Kishore Mogoluru from the US Pharmacopoeia to make a statement on their behalf.
Thank you, Chair. Distinguished delegates, the United States Pharmacopoeia recognizes antimicrobial resistance, AMR, as a critical public health threat in the Southeast Asia region. According to WHO 2017 estimates, an estimated 1 in 10 medical products circulating in low and middle income countries is either substandard or falsified. Another study by Ojwa et al. From 2018 indicates that 13.6% of all medicines in low and middle income countries are substandard or falsified, with antimalarials 19.1% and antibiotics 12.4% disproportionately affected in South and Southeast Asia. Alarmingly, studies show that up to 53% of artesunate and 47% of other antimalarial drugs are counterfeit or substandard, often containing no or incorrect active ingredients. Substandard and falsified antimicrobials accelerate resistance, compromise treatment outcomes, impose economic burdens, and erode public trust. Strengthening medicine quality across manufacturing, supply chains, and post-marketing surveillance is therefore indispensable to effective AMR containment. USP contributes to this effort by reinforcing regulatory systems, promoting the adoption of quality standards, and addressing challenges such as antibiotic shortages. We also support antimicrobial stewardship by fostering innovation and research, and by integrating quality surveillance and pharmacovigilance to detect and mitigate the risks posed by poor quality medicines. Through our public quality standards, reference standard materials, and rapid detection tools, USP empowers regulators and health authorities to safeguard access to safe, effective, and high-quality antimicrobials. USP stands ready to collaborate with WHO CRO and its member states to advance these efforts and strengthen collaborative capacity to combat AMR. Thank you, Chair.
Thank you, Dr. Kishore. I now invite Ms. Ann Nisa Renanda Prananto from the International Pharmaceutical Students Federation to make a statement on their behalf.
Thank you, Chair. It is a great honor to speak on behalf of the International Pharmaceutical Students Federation, Asia Pacific Regional Office, representing 10 member organizations from 6 countries in the WHO Southeast Asia region, covering over 35,000 pharmacy students and recent graduates, and collectively over 70,000 in the wider Asia Pacific region. We commend the WHO CRO and member states for developing the regional roadmap on AMR 2025-2030. Since 2022, we have co-organized the Interprofessional Asia-Pacific AMR Youth Forum, uniting over 600 students in medicine, dentistry, pharmacy, and veterinary sciences across the region in advancing education, advocacy, and collaboration on AMR. Our flagship project, the Asia-Pacific Pharmaceutical AMR Youth Forum 2024, gathered 200 delegates in person. Representatives from 13 member countries presented proposals for AMR awareness initiatives funded by a regional seed fund, strengthening national efforts to combat AMR. Through dedicated efforts, IPSF Pro continues to build AMR awareness and education, proving that youth are capable of leading impactful multi-sectoral engagement. We equip future health workers with stewardship, advocacy, and science communication skills. IPSF calls on WHO and member states to engage youth and civil society as partners in implementing national and regional AMR action plans, recognizing the leadership and impact we have already shown, and sustain investment and coordination across sectors in line with the Regional AMR Roadmap 2025-2030. Let our achievements serve as proof. With sustained recognition and support, youth can, and already do, drive progress across core AMR priorities. We invite member states to build upon our success and accelerate a united response in the Southeast Asia region. Thank you, Chair.
Thank you, Ms. Renanda. I now invite the WHO Secretariat to respond to the observations made by the distinguished delegates.
Thank you, Chair, Your Excellencies, distinguished participants, ladies and gentlemen. Firstly, I would like to thank all the member states for sharing the work they have been doing to take forward the AMR agenda in their respective countries. We would like to also thank you for extending your support during and the engagement during the valuable contributions you have made in the development of the regional roadmap to accelerate actions on antimicrobial resistance in the human health sector in Southeast Asia region. I do note of the different challenges which you have highlighted. I may not be able to give you an exhaustive list, but I have made a few comments, I've made a few notes here. The need for continued multi-sectorial approach and engagement, the need for working as a One Health approach, strengthening surveillance and capacities in the laboratory and beyond. Now, WHO is working very closely with the quadripartite, and this has also been highlighted in the multi-sectoral action plan. Similarly, recently, we have been engaging with the Southeast Asia Regulatory Network to see how AMR agenda can be addressed collectively between the different regulatory agencies in the country, which would be a pathway to address some of the regulatory challenges. Of course, we need to keep in mind the access versus the excess in our region. So this is something which we are very much taking it forward there. I also would like to thank the partners who have made the comments, the USP and then the Students Forum. Recently, we have also started work on understanding the curriculum of health sciences in the different countries to understand how much of AMR is being incorporated. And that would give us a good understanding and baseline to see what can be done more to address some of the issues of making awareness for AMR within the larger society, within the health sector and beyond. I would also like to thank the countries who have supported the resolution which has been proposed by Nepal. I would like to mention to you that we are working very closely with the countries to develop the second global action plan. And just last month, in a couple of months back, in September, we had a consultation where we shared the draft of the global action plan, which will be presented to the World Health Assembly next year. So we would continue to engage with you for your valuable comments into the drafts so that we can incorporate them within the stipulated times. And I would like to assure you that we will continue to work very closely with the AMR focal points in the countries to continue to understand the technical needs of the individual countries and try to bring in the relevant partners and also work towards addressing some of them. Thank you very much. And over back to you, Chair.
Thank you. I invite WHO senior management for any comments.
Thank you, Chair. Just to add from Dr. Suman, add on that we thank our member state very much on your guidance, and we take note on your guidance, in particularly the role of the WHO to help you on advocacy for collaboration beyond health sector to make a One Health approach a reality. And then on data surveillance capacity. So we believe that the regional roadmap that you support, and thank for the leadership of Nepal to table the draft resolution for this, for the consideration of our member state, will be our common framework for the way forward to address this silent killer. Thank you very much.
Thank you. Excellencies and distinguished delegates, I have the pleasure in inviting the office in charge, Dr. Katharina Boehme, to launch a publication titled Regional Roadmap to Accelerate Actions on Antimicrobial Resistance in the Human Health Sector in the Southeast Asia region 2025 to 2030. Thank you. Distinguished delegates, this brings us to the end of this agenda item. Excellencies and distinguished delegates, let us take the last agenda sub-item 8.4, Regional Strategic Framework on Combating Smokeless Tobacco, Novel Nicotine Products, and Arachnids in the WHO Southeast Asia region. Tobacco use remains the single most important modifiable risk factor for non-communicable diseases in the WHO Southeast Asia region. Despite notable reductions in overall tobacco use, the region continues to bear a disproportionate burden. The growing use of novel nicotine products, such as electronic cigarettes and nicotine pouches, and the widespread socio-cultural use of Arecanut further compound the challenge. Recognizing the urgent need for a coordinated and evidence-based regional response, the WHO Regional Office has developed a regional strategic framework to comprehensively address smokeless tobacco, novel nicotine products, including electronic cigarettes and nicotine pouches, and Arecanut. The framework outlines 7 strategic objectives representing the regional roadmap for action and aims to guide member states in strengthening governance, regulation, enforcement, cessation, awareness, research, and surveillance. The working paper, the strategic framework, along with the HLP recommendations, are now presented to the 78th session of the WHO Regional Committee for Southeast Asia for its consideration. I now give the floor to the honorable delegates to make their comments and observations on the subject. I give the floor to Nepal.
Thank you, Chair. Nepal has taken firm steps to address the tobacco epidemic. We ratified the WHO Framework Convention on Tobacco Control in 2006, followed by enactment of the Tobacco Product Control and Regulation Act of 2010 and its regulation of 2011. We are proud of the milestones we have achieved. Number 1, Nepal is among the very few countries that mandate 100% pictorial health warnings on tobacco products. Number 2, a national quilt line has been recently established. Number 3, tobacco brief interventions services are being integrated into health facilities. Despite these advances, challenges exist. While the regulations for e-cigarettes and smokeless products are in place, enforcement, particularly around marketing controls, is difficult. Vaping products are widely available and becoming popular among young people, posing a new public health concern. Smokeless tobacco is especially prevalent in our countries in the region. As this issue is unique to CR, we also work collectively to strengthen marketing controls and share best practices across borders. The Ministry of Health and Population continues to advocate for increased tobacco taxation. However, Nepal's excise tax is far below the WHO benchmark of 70% of the retail price. Encouragingly, tobacco use in Nepal is on a downward trend. However, we remain vigilant to sustain progress. As markets evolve, so must our response. We are enhancing border surveillance to reduce illicit trade, ensure compliance with national laws, and expanding awareness campaigns to protect young people from targeting marketing. Lastly, Nepal stands ready to work with the member states and WHO to exchange experience, harmonize strategies, and mobilize the collective action needed to achieve a tobacco-free Southeast Asia region. Thank you very much.
Thank you. Now I give the floor to Bangladesh.
Honorable Chair, distinguished delegates, Bangladesh welcomes the proposed regional strategic framework for combating smokeless tobacco, nicotine products, and Arecanut. Tobacco use continues to pose a significant public health threat in Bangladesh, contributing to the growing burden of non-communicable diseases. According to the Global Adult Tobacco Survey 2017, 35.3% of individuals ages 15 and above use tobacco in some form. While tobacco smoking is widely recognized as harmful, tobacco consumption in Bangladesh also includes smokeless forms and emerging products, making the tobacco epidemic more complex to address. In response to these multifaceted challenges, the government has taken several policy and programmatic actions over the years to reduce tobacco-related harm. A part of these efforts, the Smoking and Tobacco Products Users Control Act was enacted in 2005 to introduce initial controls on smoking in public places, restrict tobacco advertising, and require health warnings on packaging. In 2013, the Act was amended to expand its scope significantly, bringing smokeless tobacco under strict regulation with rules endorsed in 2015. Further supporting implementation, currently a new amendment process is underway to further strengthen the law. Smokeless tobacco use is widespread in Bangladesh, especially among women and in rural areas. Products such as Jarda Gul are culturally entrenched in expensive and often sold without packaging or health warnings. Despite serious health risks such as oral cancer and heart diseases, SLT has historically received less regulatory attention than smoking. To address this, the government published the Smokeless Tobacco Products Uses Strategy paper in 2021. The strategy outlines measures to reduce smokeless tobacco use through stronger regulation, awareness campaigns, community engagement, and integration of smokeless tobacco control into national health programs. Respected Chair, the use of tobacco products, particularly electronic cigarettes and other electronic nicotine delivery systems, has recently emerged in urban centers, especially among youth. Marketed as safer alternatives to smoking, these products pose new health and regulatory challenges. In response, the Ministry of Commerce banned the import of e-cigarettes, following sustained advocacy by the National Tobacco Control Cell. Bangladesh has demonstrated strong policy commitment to tobacco control through legal reforms, strategic planning, and enforcement. The ongoing amendment of the tobacco control law, along with targeted actions on smokeless tobacco and novel nicotine products, reflects a comprehensive and evolving national response to the tobacco epidemic. Thank you, Chair.
Thank you. Now I give the floor to the Maldives.
Thank you, Chair. Maldives appreciates the report on this agenda item and for the very comprehensive draft of the Regional Strategic Framework on combating smokeless tobacco, novel nicotine products, and Erecnut for the consideration of this committee. Like most countries in the region, we have taken stringent legislative, administrative, and executive measures to combat the tobacco epidemic. These include the total ban on e-cigarettes, banning of growing and manufacturing of tobacco products, sharply increasing taxes on tobacco, introducing licensing for the tobacco trade, raising the age limit for accessing tobacco for 21 years, and more recently, becoming the first country to introduce generational ban, which will come into force on 1st November this year. Chair, we are earnestly implementing these measures. We are also acutely aware that the tobacco industry's next generation products, like HTPs and novel nicotine products, like nicotine pouches, have arrived at our shores already. As provided in the report, the impressive looking flavor wheel with over 100 different flavors is being used to, as always, target the young generation with deadly effect. When it comes to Erecnut use, Maldives, like all other countries in our region, are seeing a dramatic shift in the way Erecnut products are repositioned, marketed, and distributed. Many of these products are infused or laced with tobacco or presented along with tobacco, providing fertile ground and opportunity for collusion with the tobacco industry. We are seeing innovation similar to tobacco products in terms of colors, flavors, product design, and presentation. Eric nut use, as having been long embedded in our society as a social prop, requires a cultural shift and grassroots level engagements grounded in awareness and advocacy, yet often neglected as a public health concern. Additionally, just as we have experienced with other tobacco products, addressing SLTs, novel nicotine products, and Eric nuts, we need to not only implement at country level and context-specific interventions, but cooperation across countries are critical in dealing with cross-border marketing promotion and illicit supplies, as well in sharing best practices. Unfortunately, we are also often at the back foot when it comes to the industry tactics to which we react rather than be proactive. Therefore, Chair, we are glad that the proposed strategic framework covers future-proofing interventions, regional cooperation, and a matrix for contextual country-level priority actions. Maldives supports the adoption of the framework and look forward to the development of tools for implementation and monitoring. Thank you.
Thank you. Now I give the floor to the Bhutan.
Thank you, Chair. Distinguished delegates, at the outset, Bhutan would like to thank the effort of the regional office for developing the framework and the consideration of the member states for placing this important agenda in the 78th RC. Last year in the 77th RC, Bhutan expressed our wish for the inclusion and advancement of discussion on this agenda. The WHO Framework Convention on Tobacco Control, FCTC, defines a list of 34 smokeless tobacco. Of that, 10 SLTs contains Erica nut as a primary composition or used with Erica nut. SLTs are used by more than 300 million individuals worldwide, with the highest concentration and prevalence in our region, which also has the greatest product diversity of SLT and Erica nut. And increasingly, our region is the most targeted region for novel nicotine products. Likewise, our region is the largest consumer of Erica nut. Current studies estimate that close to 600 million individuals chew Erica nut, and approximately 10 to 20% of the global population use Erica nut in some preparation, and mostly in the form of betel quid. And it is common knowledge that Erica nut is classified as carcinogenic in 2004 to humans, and therefore its muscatory use and consumption is associated to a wide range of adverse health effects, including oral cavity, pharyngeal cancers, periodontal disease, and of course, predominantly addiction. This situation is further exacerbated by transnational nicotine and tobacco corporations deploying aggressive marketing, digital targeting, and policy interference tactics with the intent to undermine national regulations, exploit loopholes, and jeopardize member states' effort to control tobacco products, SLTs, novel nicotine products, among others. Noting these concerns and considering that this agenda requires a much stronger, resilient, and a consolidated effort, Bhutan would like to strongly encourage member states to consider endorsing the regional strategic framework for combating smokeless tobacco, novel nicotine products, and Erica nut in the Southeast Asia region. It is time that we stand united, firm, and resolute to act with a strong political will, sustained resolve, and collective accountability to end this harmful influence and effect from use of SLTs, novel nicotine products, and Erica nut on our people's health and their future. I thank you, Chair.
Thank you. Now I give the floor to Thailand.
Thank you, Chair. Thailand wishes to express our strong support for the regional strategic framework for combating smokeless tobacco, novel nicotine products, and Erica nut. We commend the WHO Regional Office and Member State for their collaborative efforts in developing this comprehensive and timely framework. Tobacco and nicotine use continue to pose a serious public health threat in our region. While smoking rates have declined, the Southeast Asia region continues to have the highest prevalence of smokeless tobacco use and faces ongoing challenges from continuous emergence of novel tobacco and nicotine products, particularly electronic cigarette and nicotine pouches, together with the widespread use of oregano, represent evolving challenges that require collective regional action. Thailand fully supports the 7 strategic objectives outlined in the framework, particularly the strengthening of governance, regulatory measures, enforcement, cessation support, and public awareness. We also value the inclusion of oregano control, which has often been overlooked despite its strong socio-cultural roots and clear health risks. Domestically, Thailand has prioritized strong tobacco control policies under the WHO FCTC and Empower measures. We are enhancing enforcement against electronic cigarette and novel nicotine products and expanding public education campaigns on the harm of smokeless tobacco and oregano. Thailand reaffirms our commitment to advancing this regional effort and call for strengthened collaboration among member states to address cross-border challenges, including illegal trade and online marketing of smoking products. Together, we can protect our region, our young generations, and generations to come from this harmful product. Thank you, Chair.
Thank you. Now I give the floor to India.
Thank you, Chair. India understands that tobacco use remains the single most important modifiable risk factor for non-communicable diseases in the WHO Southeast Asia region. The Southeast Asia region accounts for approximately 90% of global smokeless tobacco users, bearing a disproportionate burden of tobacco-related morbidity and mortality, and faces emerging threats from e-cigarettes and nicotine pouches. As per the latest Global Audit Tobacco Survey, nearly 200 million adults use smokeless tobacco, with initiation as early as 7 years of age. Chair, India is one of the leading countries in tobacco control efforts related to smokeless tobacco as well as electronic cigarettes in the region through strong legislative measures, regulatory efforts, and stringent enforcement. The Cigarettes and Other Tobacco Product Acts regulates tobacco products, including the diverse forms of smokeless tobacco products. The Food Safety and Standards regulations prohibit the use of tobacco and nicotine in food products, further regulating some smokeless tobacco forms. In addition, the Prohibition of Electronic Cigarette Act of 2019 imposes a nationwide ban on e-cigarettes and similar devices. India also implements the National Tobacco Control Program that operates at national and sub-national levels, supporting enforcement of laws and cessation services. India also mandates large health warnings on tobacco packaging, among the strongest globally. Chair, despite our collective progress in reducing overall tobacco use, critical gaps in policy implementation continue to undermine our fight against tobacco and related substances. Many of these challenges have been outlined in the framework that are relevant to our region. Surrogate and cross-border advertising continue to be observed, especially at events that have a high number of young audience, such as national and international sports events. However, India is proud to state that it has persistently taken measures to strengthen cessation services in the country. Over 2,000 tobacco cessation centers have been established across the country at district hospitals, sub-district hospitals, medical colleges, dental colleges, tertiary care centers, etc., providing counseling and nicotine replacement therapy to users for quitting tobacco. A national tobacco quit line service is also operational in 16 languages. In addition, since 2016, India has already achieved the highest level of achievement of the O component in Empower measures. Chair, India has also taken necessary measures to educate and empower the youth of the country against the harmful effects of tobacco products and e-cigarettes. India was one of the first countries to implement anti-tobacco health warnings, disclaimers, and videos on OTT platforms, in addition to TV and films. India also supports the Tobacco-Free Educational Institutions initiative, which creates safe spaces for our students to learn and grow free from the influence of tobacco use. In conclusion, India supports the endorsement of the proposed regional strategic framework as it aligns with our comprehensive tobacco control laws and policies. We look forward to more collaboration and cross-learning from other countries in our region and beyond. Thank you.
Thank you. Now I give the floor to Sri Lanka.
Thank you, Chair. Sri Lanka is committed in reducing the prevalence of smoking as well as smokeless tobacco use. Although significant achievements have been made in controlling cigarette consumption, we have not achieved as much with smokeless tobacco, novel nicotinic products and areca nut. Sri Lanka has prioritized the control of these substances in the National Policy and Strategic Framework for the Prevention and Control of Chronic Non-Communicable Diseases, as well as in the National Policy and Strategic Framework on Cancer Prevention and Control. Furthermore, this is emphasized in the National Multisectoral Action Plan for the Prevention and Control of Chronic Non-Communicable Diseases. The country has enforced strict regulations under the National Authority on Tobacco and Alcohol Act, that is NATA Act, banning the manufacture, import and sale of smokeless tobacco, heated tobacco and e-cigarettes. Government directions prohibit betel tobacco and areca nut products in state institutions, while the Ministry of Health bans their use in healthcare settings. Despite bans, challenges persist with illicit smokeless tobacco and betel product distribution, especially in rural areas. Regulatory capacity for emerging nicotinic products is limited and lack mandatory product disclosures. Surveillance for youth new nicotinic products use is underdeveloped, and cessation services need expansion. Coordination across enforcement agencies and sustained capacity building in laboratory testing, regulatory science and health communications are critical to closing these gaps and strengthening national control efforts. Sri Lanka seeks regional collaboration and WHO support to enhance laboratory and regulatory capacity for emerging nicotinic products and smokeless tobacco variants. Technical assistance for youth new nicotinic product surveillance, culturally appropriate cessations, interventions, especially in underserved communities. WHO can play a key role in blocking the cross-border import of smokeless tobacco, areca nut products and new nicotinic products through mediation in this area. Thank you.
Thank you. Now I give the floor to Timor-Leste.
Thank you, Chair. As per the 2023 NCD Risk Factor Survey, tobacco use in Timor-Leste remains alarmingly high. Nearly 60% of adults use tobacco in some form, and 26% use smokeless tobacco. To address this, we have made a significant progress. The use of e-cigarette and vaping product is banned nationwide. Public awareness campaigns have been launched to highlight the harm of all tobacco use. The Ministry of Health, with WHO support, is integrating tobacco control into NCD and school health program. Enforcement guidelines and tools for law enforcement officers for tobacco control and current under final review. As highlight, sensitization workshop and organized for all municipality directors, including secretaries for all municipality administration, to strengthen tobacco control effort in school. In addition, no smoking signs have been installed in all schools across the country. Looking ahead, we are taking decisive steps to establish national task force on tobacco control for multi-sectoral action, strengthen enforcement and surveillance system for novel nicotine and smokeless product, expand cessation services at the primary care level, targeting both smoke and smokeless tobacco users. Timor-Leste reaffirmed its strong commitment to WHO, FCTC, and to advancing regional cooperation under this framework. Together, we can create a tobacco-free generation in our region. Thank you very much.
Thank you, distinguished delegates. I now invite the WHO Secretariat to respond to the observations made by the distinguished delegates.
Thank you, Chair. Excellencies, distinguished delegates, the Secretariat extends its appreciation to all member states for the continued progress in implementing initiatives and measures to combat tobacco use, including efforts to strengthen legal and regulatory frameworks, enhance surveillance systems, address marketing and promotion, and foster regional cooperation on cross-border initiatives. And we acknowledge and thank member states for their constructive inputs during the consultation process for the regional framework. We also recognize Bhutan's initiative in proposing this and inclusion of this agenda item, and we express our gratitude to all other member states for their strong support. Endorsing this regional framework will represent a bold and collective commitment from member states of WHO Southeast Asia region to address smokeless tobacco, novel nicotine products, and areca nut, a key risk factors contributing to the growing burden of non-communicable diseases in the region. And as requested by member states, Secretariat reaffirms its commitment to continue providing technical guidance and support to facilitate the effective implementation of the regional framework. Thank you, Chair.
Thank you. I invite WHO senior management for any comments.
Thank you. I wanted to add only a few more from our director. In terms of tobacco control, our Southeast Asia region gives a mixed message to the world. We all 10 members, we are all the conference member for the FCTC. In terms of achieving SDG target to reduce tobacco use prevalence, we are the leading to the world. And we are on track to reduce this tobacco prevalence. In terms of initiative for tobacco control, you name it, we have it. Graphical warning, I think 6 of the last 10 countries, the country with the biggest graphical warning located here in this region. We have plain package. We have India initiative on OTT. So this solves many myths into the many other countries that they cannot control advertising through the streaming, but India showed the world that we can do. Most of the country ban e-cigarette. So that is a very strong message. And on the other hand, you can see that we are the home for the world capital for smokeless tobacco. It's still very prevalent both for male and female in this region. We can see that while we ban e-cigarette, we have seen the rise of e-cigarette use, particularly among the youth population. We salute the leadership from Bhutan to table this. Perhaps this is the first in the world for framework to address areca nut. Areca nut by itself is carcinogenic substance. By itself, it can induce cardiovascular disease. But most important is that it has multiplying effect when we use tobacco. So smoking tobacco, smokeless tobacco, e-cigarette, and areca nut, these are 4 horsemen to health. So this strategic framework, as proposed by Bhutan, by Thailand, and under the leadership of Maldives for the tobacco-free generation in Maldives, this regional framework will fill the gap, will enhance our effort for tobacco control, enhance the protection for our youth and our population of this avoidable #1 risk factor for the region. Thank you very much.
Thank you, distinguished delegates. This brings us to the end of this agenda item. Excellencies and distinguished delegates, thank you all for the successful conduct of Day 2 of this 78th session of the WHO Regional Committee for Southeast Asia. The detailed agenda of the Day 3, which will also be the final day of the RC session, will be shared in the daily session journal. I am also informed that following the conclusion of this plenary, 2 side events are planned. The Secretariat will provide you the details on venue and other logistics arrangements. I urge you all to please join the event. Before we disperse, I call upon the Secretariat to inform us all on the side events and to make any other announcements.
Thank you, Chair. So we have few announcements to make. #1, we have a side event, 2 side events in this evening. First, sustaining gains, expanding horizon from a 20 years journey of regional Khalasa elimination commitment and innovation toward a healthier Southeast Asia through multi-disease elimination. So we thank the leadership from Nepal for hosting this side event. This event will be in Studio B and C at 6 o'clock. #2, developing a digital health ecosystem for integrated person-centered care. Early lesson from implementing Sri Lanka Digital Health Blueprint. So we have a co-host from Government of Sri Lanka and India. And this event will be held in this very hall and can start at 6 p.m. The third one is we will have a marathon drafting group starting at 6 p.m. in boardroom A, sorry. So start at 6 p.m. and we will finish tonight. And lastly, for tomorrow morning, we will have walk the talk event is planned to start. It will commence from the hotel lobby, Cinnamon Life at level 1, not the upper 24th floor lobby, at level 1. We encourage Minister and Education and participation to use lift lobby A that can go down to level 1, and security team will receive you at level 1 and guide you walk to the walk. The walk will be very secure. Will be from Cinnamon Life lobby up to Taj Samudra Hotel next to the beach there. And all participants are requested to gather at Cinnamon Life lobby at level 1 at 6:15, and then enjoy the walk the talk together. Thank you very much.
Thank you. The meeting is now adjourned till we meet tomorrow at 9. Have a restful evening.